you can know what is the condition of the lung depending on these four parameters. So if these things are there, then you have to consider ECMO. The second important criteria is, because ventilation and respiration involves both oxygenation and removal of CO2. So if your oxygenation has improved but your ventilation is not improving, the CO2 retention has started despite maximum ventilation. So your respiratory rate is 35, you are giving tidal volume in the form with plateau pressure ranging up to 32, and still the patient is having respiratory asthma in the form of pH less than 7.25 and the CO2 is more than 60. Then also it is an indication for starting the VVA. Other indications are bridge to transplants. So then you do not need to see all these things, and irreversible lung failure we can do it. Contraindications are very important. In such patients we should not go for ECMO therapy. This is patient with terminal respiratory failure where we do not have an option for lung transplant, or the patient is having severe brain injury in the form of bleed or hypoxia, whatever is there. So then we should not go for these are absolute contraindications. And relative contraindication, if the ventilation has happening for more than 7 days, coagulation abnormalities, active bleeding, immunosuppressions. These were earlier they were more in absolute contraindication, but as the expertise has increased, now they are into the relative contraindication. For such patients, you need to be a very expert in ECMO management. Before starting ECMO, you can prognosticate as well. You can use this score, RESP score, and these are all the parameters which you can use it. And more the negative number is, poor of these the outcome. So what is the difference between a VV ECMO and VA ECMO? So VV ECMO, what we are doing is we are taking the blood out of a venous system and putting it back into the venous system. So it is a single system. And in VA ECMO, the blood is being taken from venous system and it is put into the arterial system. So it is a little complicated system. Okay. So these are the major differences. So once we start our patient on VV ECMO, the goal is to first improve the oxygenation of the blood and aid in the removal of the carbon dioxide. That is what we want to achieve. We just want to provide adequate oxygenation and ventilation. We do not want our patient's saturation to be 100%. If it is between 85, 88, 90%, it is good enough for survival, and we should aim for that only. And as the work of the lung is now being done by the ECMO, we provide rest to the lung. Okay, so ventilation is reduced so that ventilator associated lung injury is reduced, and that helps in recovery of the lungs. So this is our circulatory system, and in humans we have lungs, heart and vessels as the major part of the oxygen delivery. Similarly in ECMO, we have the alternatives for that. So for lungs, the work is replaced by a membrane oximeter. The heart work is replaced by a pump, and vessels are in the form of tubes. So once you start your VV ECMO, you have to institute a drainage cannula. You need tubing so that blood can be aspirated, and that aspiration or that calculation is done by the pump. Okay, so pump is rotating and that is creating a negative pressure, and blood is suctioned into the ECMO circuit. This pump is controlled by the console. You can increase or decrease the rotations as per the patient's requirement. Then the blood goes into the oxygenator where the oxygen is provided and carbon dioxide is removed. It is controlled with the help of blender, and then the oxygenated blood is returned back into the circulation. So this is what we do in ECMO, and this is the basic circuit of a ECMO. During this, blood is coming out, so there is a chance that the patient's the blood temperature can go down. So you need to always keep a heat oximeter so that the temperature is maintained. And since the blood is coming out, it can coagulate and it can lead to clotting. So you have to always anticoagulate such patients. So when we start our VV ECMO, so we have three major configurations which we can use. So these are femoro-femoral, femoro-jugular and double. So what do we mean by femoro-femoral? That means the blood is taken from one femoral vein and it is returned into the another femoral. So this is what we do in femoro-femoral. this is the one femoral, this is going into the IVC. This is the drainage cannula, and we see that there are a lot of holes inside this drainage cannula so that the maximum amount of blood can be aspirated to the IVC. The location is just intrahepatic, so where the hepatic vein is drainage into IVC, the tip of the cannula is just below that. And the other cannula, so this one is the return cannula, and we see that the location of return cannula has to be in the right atrium so that the blood which is oxygenated is now directly going into the heart. Okay, so this is the femoro-femoral configuration. The second one, more commonly instituted one is the femoro-jugular, where we institute in two different veins. One is in femoral vein, so that is again the drainage cannula, and the location is similar at just below the hepatic vein opening at the IVC, and the return cannula is in the IJV, and again the direction is towards the right atrium and going into the tricuspid wall so that it can be going into the heart directly, the oxygenated. The third one is the double lumen or two-stage single cannula, so that is the Avalon cannula, and we see that the system of the Avalon cannula is such that we have two drainage ports here, so it is draining from the lower part as well as from the IVC as well as the SVC, and we see here that this is the return cannula. It is inside this whole cannula system, and the direction of this opening of the cannula should be such that it is directed towards the tricuspid. So the positioning of this cannula is very important. It has a major advantage that you need only one cannula and patient can immobilize easily, but the disadvantage that if it is moving and if the direction is not proper, then your efficiency will reduce considerably. So once we put the patient on ECMO, so do we get 100% oxygen? Never. So what is the reason? The reason is that when we are putting a ECMO cannula into the for the drainage, it is put into one IVC, okay, but some amount of drainage is happening from the SVC as well, which is we are not draining. So the whole amount of blood is not coming out in the ECMO circuit, and that is why you cannot oxygenate all of the blood. So it will be only a part of the blood which is going to be oxygenated when we are putting patient in UVA, and we also do not require such amount of oxygenation. So the studies have shown that around 60 to 80% of the patient's cardiac output is good enough if we are oxygenating this amount of percentage. Right. So if the total body's cardiac output is around 5 liters, then ECMO flow requirement will be around 3 to 4 liters. So that is good enough to oxygenate and sustain the life. We do not need to do 100%. So if the ECMO flows goes down or it increases, then it will result into complications as well. So if the ECMO is less than 60% of the cardiac output, then it will be inadequate oxygenation. So hypoxia will be there. The reason why you have put the patient on ECMO is not working. If the ECMO flows are more than 80%, then it will lead to recirculation. Okay. What is recirculation? We will be discussing in further stage. So the cannula size, what we need to insert into the patient, the drainage cannula size and the return cannula size depends on the requirement of your ECMO flows, and that is dependent on your cardiac. So you have to take patient size, weight, vessel diameter and desired blood flow before you can decide what cannula insertion you have to do into the veins. Okay, so you have calculated the cardiac output, you have calculated estimated blood flow requirement, and depending on that you can choose the cannulas. So cannula size range from 13 to 31 for an average adult. The drainage cannula is 23 to 29 and return cannula is around 17 to 19. That is good enough for most of our patients. You can also use ultrasound for determining the cannula size, because you may have a situation where the particular vein is little smaller than expected. So you should always look at the ultrasound, you should measure the IVC, you should measure the femoral vein, you should take the caliber of that, and the cannula should be only 2/3 of the total vessel diameter. The tip, the location of tip is very, very important. So the jugular cannula tip should be at the SVC RA junction, and the femoral cannula should be at the IVC at the level of hepatic vein, because at that level the IVC is anchored to the surrounding tissues and it does not collapse easily. And so the collapsibility or the chattering will be lesser. You can confirm the tips with the help of fluoroscopy, ultrasound, X-ray, TE. You can do whatever is available to us. And the distance between the two cannula is very important. It has to be kept around 10 to 15 centimeters apart, because if it is too near to each other, then recirculation will happen. So we have put the patient on ECMO. So what will be the determination of the ECMO flows? Okay. So we have to see the blood flow as well as the oxygenation. So blood flow is determined by the pump. As we have it for the heart, preload, afterload, anotropy, we have similar thing for the ECMO pump as well. So this is our pump, and things before the pump act as the preload of the pump. So the cannula size, the drainage cannula, whatever is the lumen of the cannula, so these are the preload. So patient's heart, venous system, everything is the preload. The blood pump, whatever is the rotation per minute, is actually our ECMO inotropy. And whatever is after the clump will result into the afterload of the ECMO. Okay. So ECMO afterload is determined by the vascular resistance, return cannula characteristic, and length of the tubing between the oximeter and the pump. Okay, so if your ECMO blood flows are reducing, then you have to analyze in this form only, that whether my preload is a problem, whether my rotations is a problem, or my afterload is a problem. The exchange of oxygen happens on ECMO with at the membrane oxygenation, just as it happens in the lungs. Similar thing is happening at this level also. In the lungs, it is dependent on the blood flow to the lungs. It is dependent on the oxygen in the lungs and in the diffusion across the membrane in the lung. Right. Similarly, here on ECMO, it is dependent on the blood flow to the ECMO. It is dependent on the FiO2, the inlet SiO2, and it is also dependent on the membrane capacity. This is similar to what is happening in our own physiology. And carbon dioxide in our normal humans, it is dependent on the alveolar ventilation, respiratory rate and tidal volume. So here the ventilation is controlled with the help of sweep gas flow. So if you increase the gas flow, the CO2 will go down. If you decrease the gas flow, the CO2 will go up. So when you start your ECMO, you have to understand these principles. Okay, then only you should start. So pre-initiation consent is very important. Then you have to prepare. Key rule of a ECMO circuit is that it should be short, simple, and with the fewest possible connections. You can have a pre-formed kit or you can assemble yourself depending on the availability, and then you have to prime the circuit. When you are initiating, cannula can be inserted percutaneously or surgically. The blood flow we usually start with 20 ml per kg, then we increase it to 60 to 80. The sweep gas flow is kept as around 1:1, so that the gas flow is equal to our blood flow which is happening in the ECMO circuit. So if the ECMO circuit blood flow is 3 liters, we keep the sweep gas at 3 liters to start with. The target here is that if there is hypercarbia, we want to reduce it gradually. If we do it very fast, then it can lead to neurological complication. And the ventilator settings. So once the work of the oxygenation and ventilation has been taken care by the ECMO, we have to reduce our ventilator settings to give rest to the lungs. So these are known as rest ventilator settings. So what are these rest ventilator settings? So tidal volume should be as low as possible, around 4 ml per kg, or if the patient is put on the pressure control, the delta pressure should be around 10 to 15. The plateau pressure should be reduced so that there is no lung injury. It should be targeted less than 25, and delta pressure should not be 15. And respiratory rate is also kept very low, from 4 to 15, around 10 to 15 is usual. PEP is kept around 10 to 15, and FiO2 is also reduced so that all the parts of ventilator associated lung injury, barotrauma, volume trauma, epileptotrauma, these all things are reduced. Then we have to anticoagulate the patient. Heparin is the choice. It is usually monitored by ACT. ACT targets are around 160 to 200 in ECMO. And if bleeding is the major issue, and if you have encountered heparin resistance, then you can go for alternative as a bivalent. You have to continuously monitor the patient. You have to see the hemodynamics. You have to see the oxygenation, ventilation. You have to do ABGs, and you have to see the ECMO circuit. This is very important. Okay, so you have to visualize the entire ECMO circuit right from the cannula position to circuit, tubings, oxygenator, pump. You have to see whether there is any leakage, infection, clot, anything is there. Then you have to do changes accordingly. So ECMO circuit monitoring is very important. And we also do a lot of pre and post oxygenator ABGs to see the membrane efficiency. We have to check the pressure across that oxygenator, that is known as delta pressure. So that is again an indicator for membrane efficiency. Lab monitoring is very important. Apart from routine CBC, you have to look at the other organ failures. So you have to go for RFT, LFT, and you have to see the coagulation profile. You can do an X-ray so that we see that there is any recovery in the lungs. Neurological and is very important again because the patient can bleed. It can bleed in the brain as well. So you have to always ensure that you stop the sedation daily and check the consciousness daily. And you have to look at the surveillance cultures and infections, very important. Don't forget to give very good general critical care and treat the disease. Because if you do not treat the disease, the patient cannot be endlessly on ECMO. Infection prevention, physiotherapy, nutrition are very important. So coming to some troubleshootings, common troubleshootings. So what is happening here? This is the oxygenator. We see that the two pumps, two circuits are there, and we see that the color of the two are almost similar to each other. This is what a normal should look like. So this is the drainage, which is very deoxygenated blood, and the return is oxygenated. Here the difference is reduced. So what is happening here is the recirculation. This is a common complication in a VV ECMO patient. Why does this happen? So the oxygenated blood is returned from the ECMO circuit into the RA, immediately draining from the RA into the draining cannula. So we see here that this is the return cannula. The blood is coming into the RA, but majority of part rather going into the heart, it is being sucked from the drainage cannula. So what does it mean? That the oxygenated blood rather going into the patient is going into the circuit. So the circuit will become red. Okay. And the patient is not getting enough oxygenated blood, so patient will become hypoxic. So the suspicion is when you have started the ECMO circuit is whole oxygenated, but the patient is hypoxic. That is where you have to suspect recirculation. So what are the most common cause? When the two cannulas are very close to each other. So if they are very close to each other, the blood will circulate in the circuit only, and it is not going to go into the patient circulation. Or the flow is very high. Okay. So if the ECMO flow is very high, it will have a negative pressure which is more than the what is there in the patient's heart. So it will go into the patient's the ECMO circuit, and it will again result into the recirculation. So what do you do to treat this? You have to confirm the position of cannula, and the difference should be at least 10 to 15 centimeter. You try to reduce the ECMO flow, and if the patient's oxygenation is improving, that means recirculation is there. And withdraw and readjust the cannula, and sometimes you have to go for another drainage cannula if you have done all these things and patient is not improving. Another common complication. Working. So what I wanted to highlight here was the chattering. So this happens when So this is another very common problem. This is circuit dancing. So this is what we call as chattering. So what happens here is that this is a rhythmic vibration of the ECMO tubing, and it is caused when the drainage is very less. Okay, and the drainage cannula is abutting the vein wall. Okay, so if your patient is hypovolemic, when the ECMO will squeeze out the blood or suction it out, then this drainage cannula will abut the venous wall and the blood flow will not come. So your ECMO flow will continuously reduce, and then when the ECMO flow is reduced, then again your vein will be released, and then again flow will increase. So your flow will be increasing, decreasing, and you will see such problem. So there is reduced ECMO flow causing hypoxemia, and it will also lead to more hemolysis and cavitation. Management is to optimize your flow. Another important thing is hypoxemia happening on ECMO. So we studied about the physiology. In physiology, the oxygenation is dependent on the blood flow and the membrane efficiency and the FiO2. These are the three major things. So you have to look at the blood flow, whether there is inadequate blood flow, which is leading to hypoxemia. If that is there, you have to correct that. For correcting that blood flow, you have to check at the preload of the pump, afterload of the pump, and the RPMs. There can be cannula malposition, that is also leading to an inadequate blood flow and high native cardiac output. So you started with a cardiac output, suppose 4, but patient goes into the sepsis, fever is there, and your internal cardiac output now increases to 5, and your ECMO flows remain at 3. Then the effective oxygenation has reduced. So if you are oxygenating 3 liters at 4 liters of cardiac output, you are oxygenating 75%. But if the internal cardiac output has increased to 5 and your still ECMO flow is 3, then you are oxygenating only 60%. So that will lead to hypoxia. So you have to look at that part also. Then you have to look at the oxygen deliveries. You have to always check the oxygenator dysfunction, so that you have to always check the delta pressures. If that is happening, then you have to correct the problem, and if that is not improving, then oxygenator has to be removed. You can optimize your ventilator settings, and you can reduce the oxygen consumption also. So sepsis will again lead to requirement increasing. So you sedate the patient, you paralyze the patient, you treat the fever. And another last is recirculation. So if recirculation is there, then you have to treat the recirculation, which we have already discussed. Coming to last, VV ECMO weaning. Weaning is not very difficult. So we have to look at the oxygenation as well as the ventilation. So first, as we go for the ventilator, resolution of disease has to be there. You do an X-ray, you see there is an improvement. The patient hemodynamic is okay. You do an oxygen concentration test. What we do here is, at the same ventilation settings, we just increase the FiO2 of the ventilator. If increasing the FiO2 on the ventilator is leading to improvement in the saturation considerably, that means my oxygenation is happening very good at the ventilator. And that can be a starting point whether I can go for starting of the weaning. Okay. And you always should do a bronchoscopy so that the secretions which are pulled up are cleaned out. Then you increase your mechanical ventilation settings to mild to moderate settings, like FiO2 is around 40-50%, PEEP of around 8, and tidal volumes and plateau pressures are also reasonable. And then you gradually start reducing your ECMO blood flow, ECMO FiO2 to reduce the oxygenation from the ECMO, and you start reducing the sweep gas flow so that you reduce the ventilation part. So if you are reducing it and the patient is maintaining on reduced flow, that means your lungs are ready to handle the load from the ventilator itself. And if it is successful when everything is zero, like the sweep gas is zero, FiO2 is zero, that means no contribution is happening from ECMO and your patient is maintaining. That is the time that we can decannulate and take off from the ECMO. So what happened in our case also, so VV ECMO was started, we put the patient on femorojugular configuration, no complication happened during the insertion, ventilator settings were reduced to the rest ventilator settings, and the oxygenation and ventilation was controlled by ECMO, AC3 monitoring was started for heparin. We did a bronchoscopy and tracheostomy on ECMO. ECMO, we can do all these things, it is not a major complication, we have to be a little careful. So her lungs were still not improving, and she was not having fever because the temperature was controlled from ECMO. The patient will not have any fever, but the TLC were rising, so we suspected that there might be some second infection. We did a BAL culture and it showed Cryptobacterium. So Cryptobacterium, the characteristic of this bug is that it is resistant to colistin. So blindly treating the patient, like if the patient's X-ray is bad, so you start polymyxin B or ceftriaxone, this is not right. You have to find out what is the reason for deterioration and treat that. Then only your patient will improve. So antibiotics for this patient was changed to minocycline levofloxacin was given, and then she started to respond, and gradual weaning from ECMO was done. She required ECMO for 19 days, and then weaning from ventilator was also done. She remained in ICU for 37 days and went home after 44 days. And now she is leading a normal life. So to summarize, these are the important things about ECMO. So indication has to be a refractory respiratory failure. You have tried your other things, not working. But important is you identify as early as possible, because earlier you start, better are the outcomes. You have to define your purpose, whether it is bridge to recovery or transplant. Your goal is very clear that you are going to give rest to the lungs, so you have to go on to reduce ventilator settings. Circuit is only in the venous system, so it is little simpler. VECMO is little more complicated. You have to understand the oxygenation and the ventilation. Configuration you have to pre-plan whether you are going to go for femorofemoral or femorojugular or Avalon. Monitoring and troubleshooting is key, and weaning should be done once disease resolution starts. And don't forget to provide excellent general critical care, because without that, the patient will not, your ECMO will not be successful. Thank you.
Thank you, Dr. Kishore, for this insightful and thoughtful, informative session. I just have question. Like any indication of directly starting ECMO before proning session, before going to proning?
Ideally, we should not do that. We should always give a chance of proning. We have all seen that proning works like magic, and for most of the patients, it is helpful. There are some non-responders as well, but that can only be 100% be sure that when you do a prone and the patient has oxygen is not available. Or if the patient is too unstable for doing an proning, or there is a contradiction, then you have to go for ECMO. Otherwise, we always try to go for proning. And we have seen that once the oxygenation and the ventilation improves, it also leads to improvement in hemodynamics sometimes. Because if the hemodynamics is getting compromised because of hypoxia or acidosis, then proning will help in that.
So after how many sessions we get to know that this patient is not going to respond to proning?
We can know within few hours also, within one session also. Like this patient we did for five
sessions.
So you have to be continuously vigilant. So for first 5 sessions she was responding, the FiO2 was reducing from 100 to 40, 50.
Because
so
sometimes this patient deteriorated very rapidly.
Yes, so it happened with this patient also. On the 7th day, the FiO2 was not reducing at all. So then and there only we decided that we should go for it.
Thank you, Dr. Kishore. It was a really wonderful talk. You covered almost all aspects of VV, ECMO and ARDS. And possibly, I have just a query regarding VV and ECMO and ARDS. Is there a difference between the etiological factor where the response is better in terms of either primary or secondary ARDS? Is there a difference as far as VV ECMO is concerned?
So, when we see the RESP score, they have defined that for certain diseases it is bad, and for certain diseases it is good. Like for status astigmaticus or early ARDS, it has got a good response. So if the patient is in late ARDS, the patient is already gone into the fibrotic phase, and if you are starting ECMO at that time, it is the response will be very delayed, and you can land up into a situation where the patient becomes ECMO dependent. And in COVID-19 patients, we saw that the results were very poor. So disease is very important.
Phenotype definitely.
And phenotype also definitely. And timing is very crucial.
So the house is open for any questions.
Dr. Kishore, whenever we take a decision for VV ECMO, most of the time patient land up into shock state, and sometimes even patient on high blood pressure support like 0.5 to 1 mics per kg per hour. So it's always a dilemma. Although we know that most of the time patient shock reason is due to hypoxemia, hypercapnia, and acidosis. And when you put on ECMO, that part will be taken care. But still, you confirm with the echo the myocardium dysfunction, because sometimes we also dealing with septic myocarditis, viral myocarditis, postpartum myocarditis, or any cutoff value, because most of sometimes even very high doses of vasopressor support. So when we are going straight away for BB, or we are going opt for BA.
So as such, I don't know about the exact cutoff values, but what we do in general as a principle is that if the patient is having hemodynamic instability, which is significant, and there is myocarditis-like situation, then you can opt for VA ECMO. If the patient is having predominantly vasodilatory shock, even VA ECMO is not going to be very much helpful. Then you should think whether we should go for ECMO at the first place or not, because the patient is having shock, the patient is having ARDS, most likely the patient will have renal dysfunction also. So if the patient is already into a multi-organ stage, probably we are late at this stage. So both VV and VA may not be very helpful. So we have to select your patient very carefully.
Dr. Kishore, in continuation to what Dr. Modi was asking, one of your slides showed the criteria for selection of patients, and it said 6 hours of not responding to the best lung protection ventilation. So if you plan a prone cycle for say 16 hours, and in 6 hours hardly few of the patients will improve. So that does become an indication to switch over to
At least
the
once
first
I
cycle
start discussing it, this discussion has to be initiated.
and not even wait for completion of first cycle.
Not mandatory. Okay. Not mandatory. That you have to complete the whole cycle. If the patient's mechanics have not improved, you are seeing many things. You are seeing the CO2, you are seeing PO2, you are seeing the mechanics, you are seeing the plateau pressure, you are seeing arterial CO2 gap. So you are looking at many parameters. And also the vitals, if the vitals are improving or not. So you have to be certain that you are seeing some signs of improvement. If there are some signs of improvement, one thing can be like oxygenation may be improving after 8 hours, but your CO2 has started to improve, or your plateau pressures have started to reduce. Then it is also indication that probably this is working. If nothing is improving and the patient is deteriorating, then we should not wait for the whole cycle.
So 6 hours is good enough in that scenario.
As per the OJS criteria, 6 hours will be good.
Thank you.
Hello. Sir, venous ECMO is primarily for lung condition. Sir, can it be beneficial for heart also, especially right ventricle?
So right ventricle definitely, if in ARDS we see right ventricular dysfunction is there, and if there is right ventricular dysfunction because of hypoxia or hyperthermia, if you are instituting an ECMO for that, then RV dysfunction will also improve. But if it is a predominantly RV failure only without having any hypoxia or hyperthermia, then it will not be of much importance.
Yeah, the question which Dr. Anil was asking is that whether to select the VA or BB ECMO in cases where you are using a higher doses of vasopressors. I think doing echo is the good idea. If you are doing an echo and you find that the EF is 30% or more than 30%, probably we should go for a VB ECMO, and most of the time you will be able to decrease the vasopressors because the requirement is because of the very high plateau pressure and all those things. So that is one thing that we should not ideally or initially select going for VA ECMO if the EF is but yes, if EF is going less than 25%, you can think that besides the ARDS, the patient has got either a septic cardiomyopathy or the patient has got a viral myocarditis. In that case, we have to go for a VA ECMO as an initial prerequisite. And what he's talking about now, many times regarding the flow, we try to achieve a higher flow, 4.55 liters. But what the recent concepts are coming, if you're trying to receive a higher flow in VV ECMO, probably you have to give a higher level of fluid and with the blood transfusion. So which is not good for VV ECMO patients because it is ultimately going to have more and more lung injury. So nowadays we are trying to accept a flow of anything which is more than 3 or 3.5 liter but the patient is maintaining saturation of 90%. That actually going to prevent the SARS related things, and also you are limiting the fluid that can lead to more and more pulmonary edema. So this is the new things we are trying to do in those patients who are putting initial, because if you put the patient on VV ECMO, the initial response is the SARS response. And the SARS response can go more and more vasodilatation for first 24 hours. And what our approach for that patient is that give more and more fluid if the patient has gone in the SARS response. And that actually delays the lung recovery. So use vasopressors and don't taper vasopressor very fast. Don't taper ventilator very fast, and continue and wait for 24 hours. Your things are going to be stabilized.
So just like what we do in ARDS, we have to keep our lungs as dry as possible.
Yes, that's what
our
an
target
ECMO
is.
is.
Thank you, sir.
Our next speaker is Dr. Ravi Jain. He is very young and dynamic. Dr. Ravi is Associate Professor, Department of Critical Care Medicine, Mahatma Gandhi Medical College, and his area of interest is biomedical research and methodology, ICU quality, safety, medical ethics, and evidence-based medicine. So, over to Dr. Ravi, and his topic is role of plasma exchange in current ICU practices.
Good morning, everybody. Thank you to the organizing team over here to call me up for this presentation, and respected seniors, my colleagues, everybody. So I'm here to talk about the plasma exchange therapy in current ICU practice. So before starting, for the core things that we need to know about plasma exchange, let's see some cases that we have done in past 1 year at our institute. So to build up on the presentation, this is a 34-year-old female, 36-week pregnant with PIH and on labetalol, who presented with dyspnea and developed multiple organ dysfunction. Labs revealed that she is having renal failure, creatinine of 2.5. She has severe anemia, thrombocytopenia, elevated liver enzyme, hyperbilirubinemia, and coagulopathy with INR of 2.6. She underwent LSCS but continues to deteriorate on ventilator support. Most likely the diagnosis is HLLP syndrome. Okay, getting my point? But the management includes what? Delivery and supportive care. But what if she doesn't improve even after your supportive care? Let's move to the case number 2. This is a 20-year-old male with recent history of diarrhea who developed rapidly progressive weakness starting from lower limbs to the upper limbs. And now respiratory failure is also there. Patient is on ventilatory support with ICU. Care is ongoing. MRI brain, spine, EEG, everything was done and turned out to be negative for everything. Nerve conduction studies was done, and patient is having bilaterally reduced conduction velocity with prolonged distal latencies. Most likely diagnosis is Guillain-Barré syndrome. Okay, but what the management includes is IVIG therapy either therapeutic plasma exchange. Then this is the case 3. 65-year-old male with carcinoma prostate, post-chemotherapy, radiotherapy status, admitted to our ICU with altered sensorium. The patient was intubated. Investigations show renal failure, creatinine of 5.5, anemia with hemoglobin of 7.5, reticulocytosis. Patient is having thrombocytopenia of 24,000. Mild liver dysfunction. Peripheral smear is showing cystiocytes, microcytosis, and low platelets. Most likely diagnosis over here is because of the high plasmic score, patient is having thrombotic thrombocytopenic purpura. Grade 1 indication for therapeutic plasma exchange in this condition. So, now moving on to the case number 4. There is a 45-year-old female, post-operative cases of right frontotemporal space occupying lesion, which was operated. Now the patient was discharged on phenytoin and Lavapil. She now presented with fever, progressive truncal, upper limb rashes, oral and mucositis, ocular mucositis. More than 20% body surface area is involved. So likely diagnosis is Stevens-Johnson syndrome. Okay, which was possibly drug-induced, Phenytoin-induced Stevens-Johnson syndrome. The management includes over here is supportive care and removing the insulting agent, but what if she doesn't improve? So coming to the common converging point of these 4 cases, these are wide variety of cases, different organ systems are involved. So the common converging point over here is the plasma exchange therapy that we have provided to these cases. And all the cases did well in the end. So how do we select these cases? That is the most important thing in plasma, therapeutic plasma exchange as far as the critical care medicine is concerned. So this is American Society for Apheresis Guidelines of 9th special issue, which was published in 2023. They provide wide variety of indications. Clinical indications can be many and ever evolving. They provided them in 4 specific categories. The category 1, where the indications are the first line therapy is therapeutic plasma exchange, like thrombotic thrombocytopenic purpura, myasthenic crisis. Category 2, where the indications can only be second line options. Okay, you did all the first line options, and if it does not improve, then go for the second line therapy. Category 3 indications, where the plasma exchange therapy is not well studied, but physiological plausibility is there. So you use it when an individual case is guiding you to use it. Then category 4, where indication is proven to be, therapeutic plasma exchange is proven to be ineffective or even harmful. So do not use it over there. So moving on to the quick and crisp, high likely indications that come across our clinical practice day in and out. So first of all, AIDP, Guillain-Barré syndrome, which is in Guillain-Barré syndrome. The therapeutic plasma exchange is an established therapy. It speeds up the motor recovery, reduces ventilator days, improves the ambulation if started within 7 days. Okay. Comparative study with IVIG therapy showing equal response with the therapeutic plasma exchange also. Relapses can occur though with a similar frequency of IVIG therapy. It can be cost effective also in Indian settings if we modify our strategy somewhat. So therapeutic regimen is like 5 to 6 exchanges over 10 to 14 days, replacing 1 to 1.5 plasma volume with albumin or plasma. Then second most common indication that why we use it for is myasthenia gravis. Myasthenia gravis apheresis rapidly lowers the autoantibodies that are targeting our system. Okay, so it provides miraculous response sometimes. Okay, so it is especially indicated when myasthenia crisis is going on and severe bulbar or respiratory relapses are happening to the patient. Okay. There are some studies and meta-analysis that show that TP is as effective as IVIG therapy, but may reduce ventilator time and may be more useful in severe MuSK positive cases. Typically 3 to 6 sessions are given over a period of 1 to 2 weeks with immunosuppressive therapy added for a long-term control. Then acute liver failure. In acute liver failure, therapeutic plasma exchange helps in many ways. Basically, toxins, it removes ammonia, metabolites, disease-associated molecular patterns, improves cerebral hepatic flow and hemodynamics. The evidence shows that it improves the transplant-free survival, decreases inflammation in the body. It is used mostly to bridge the recovery to transplant. Often CRRT and MARS is used simultaneously with these cases. Okay. In acute fatty liver or pregnancy, combined therapeutic plasma exchange and CRRT have been reported safe and effective, but not used so many times, and it is not a very high-grade indication for that, acute fatty liver or pregnancy. Then glomerular basement membrane disease. In anti-GBM disease, the key problem is circulating pathogenic antibodies. Okay, so it is causing severe kidney and lung injury. Historically, about 90% of the patient of these problems used to die because of alveolar hemorrhage. But as the therapeutic plasma exchange started to coming up after 1970s, the survival improved after therapeutic plasma exchange therapies availability. So it also helps in antibody decline faster and resolve MUPSIS. With therapeutic plasma exchange, about 40 to 45% patient can avoid end-stage kidney disease and death. Catastrophic antiphospholipid syndrome and acute toxins, venoms, poisons, where the indications can be innumerable and many. Thrombotic thrombocytopenic purpura, I would like to specifically point it out. The TTP plasma exchange with plasma replacement is the life-saving and has transformed outcomes in TTP. it works by removing anti-ADAMTS 13 antibodies while replacing ADAMTS 13 activity, that's supplying plasma. Okay, the treatment is given daily until the platelets rises above 1,50,000 and above. Because of large plasma volumes are used, allergic and citrate reactions are relatively common. So we need a tapering schedule sometimes attempted. Evidence shows that they don't reduce relapse rates. Overall, therapeutic plasma exchange is the cornerstone therapy for thrombotic thrombocytopenic purpura. Then multiple sclerosis, hyperviscosity syndrome, sepsis. Okay, this is one interesting indication. It has been studied widely in different kind of sepsis. Sepsis, septic shock, plasma exchange may help by removing inflammatory mediators. This is a physiological possibility behind this. Removes inflammatory mediators, antifibrinolytic factors, while it replenishes the proteins like ADAMTS 13 to restore hemostasis. Observational studies showed that higher survival, especially with early use, is there, but randomized controlled trials are not showing any benefit. So there is a big question mark behind sepsis for plasma exchange therapy. But it has been used, so that I have, that's why I have included in my presentation over here. But there is no clear survival benefit. Therapeutic plasma exchange, some observational studies are showing that okay, there is some benefit, but not replicated in large controlled trials. Although COVID-19 evidence is somewhat more favorable with improved oxygenation and inflammatory markers, but overall data are inconsistent. Biological rationale is strong, but we do not use it. I will discuss it later on why we do not favor it to use therapeutic plasma exchange in sepsis. So this is one more common indication after kidney transplantation in AVA incompatible and compatible kidney transplantation. So a whole lot of list is there. Innumerable indications, not innumerable, but 91 diseases and 166 indications in about 4 categories in 2 grades are there. So indications are wide. We need to keep our eyes open when we can use the therapeutic plasma exchange. So before, what is important to us is basically to understand how it works so that we can keep our eye open and use it in our clinical practice. How do we do it? So let's understand the terminology first. One common question is the difference between plasmapheresis and plasma exchange. Plasmapheresis strictly means removal of plasma only. Okay? Whereas in contrast, plasma exchange, also called therapeutic plasma exchange or PLAX, involves both removal and replacement of the plasma. The term often used interchangeably in practice, but technically they are different. Okay? Plasma exchange and plasmapheresis both are different. Plasmapheresis, like we have used in convalescent plasma pheresis for COVID-19 patient, whereas plasma exchange therapy, as I have talked already about. So what is the principle? It is very simple. Blood is 2 components. One is plasma, other one is cellular component. Cells are different: platelet, lymphocyte, granulocyte, erythrocyte, etc., etc. Not etc., but actually these 4 quality of cells are there in the blood. Then plasma. Plasma contains all kind of proteins. Okay, all kind of proteins, all antibodies, all kind of fighting antibodies, cytokines, pro-inflammatory, anti-inflammatory cytokines. Everything is there in plasma. So what you do, basically you remove. This highlights the core principle of therapeutic plasma exchange. In this procedure, the plasma is selectively removed, while cells, red cells, white cells, platelets are returned safely to the patients. Okay? The aim is to clear the blood from harmful substances such as antibodies, metabolites, immune complexes, and certain metabolites also, immune complexes mostly we use. By removing these, therapeutic plasma exchange helps to restore balance. Okay? It improves the outcomes. In essence, it provides targeted removal of pathogenic plasma components. Okay? Then, how can we do it? There are basically 2 different modalities how we can perform a plasma exchange therapy. One is centrifugal technique and one is filtration technique. What happens in centrifugal technique? Basically, the blood is spun through the specialized machine, and by selective density of the different components of the blood, the plasma is separated. Okay? And it has been exchanged with the targeted material that you have selected, maybe plasma, maybe albumin, whatsoever. Then filtration technique, specialized membranes are there to selectively filter out the cell components and plasma. When the patient is on hemodialysis or going on with a CRRT or something like that, renal support is going on, then plasma filtration techniques are used. Otherwise, Mostly we use centrifugal technique. At our institute at least, we are using centrifugal technique mostly. Then this slide highlights the key factors that influence the outcome of plasma exchange therapy. First, the patient's plasma volume. It is important how much plasma volume is there and we are going to replace it. So it is very crucial component. Since the amount removed is proportional to it. The second is the quantity of the substance available for the removal, which depends on whether it is present mainly intravascularly or it is distributed throughout the system and different tissues, deep tissues. Finally, the mobility of these substances between the compartment, which is critical, as effective clearance requires continuous movement into the bloodstream. And this diagram highlights the interplay of these factors. Okay. There are certain prerequisites before going on with the plasma exchange. So before starting plasma exchange, baseline assessment is very crucial. So blood grouping, antibody screening is done first. Weight and height noted for the plasma volume calculation. Hemoglobin should be above 7 gram per deciliter that we target. Hematocrit over 20% and platelet count of more than 50,000 to reduce the bleeding risk, what we target in our patients. Ionized calcium, it must be maintained between 1.16 and 1.31 millimole, since the citrate anticoagulation is going to be there with the amount of the plasma that we are replacing. So it can lower the calcium levels. Finally, serum electrolyte and protein should be checked as they impact both safety and efficacy of the procedure. These are the consent forms. So first you check the patient, you take the informed and written consent, you explain them what can go wrong with the plasma exchange and what is going to be the benefits of the plasma exchange. Then you go ahead and do it. Efficiency of plasma exchange is directly proportional to the amount of plasma that we are going to remove. When we exchange a volume equal to the patient's total plasma volume, we call it one volume plasma exchange. Okay? Then this typically reduces about 30% of the unwanted substances present in the plasma. To achieve a higher clearance, multiple sessions may be required, or maybe you can go for a higher volume of plasma exchange. But there is a catch. One volume plasma exchange removes 30%. Escalated one more volume will remove only additional 10% of the volume. So efficiency drops with higher volume plasma exchanges. That's why a double or triple volume exchange only removes about additional 10% of unwanted substance each time. So because of the diminished return and the safety concerns, the recommended practice is to remove only 1 to 1.5 plasma volumes per procedure, which balances efficacy and safety. Okay. Replacement fluid. Coming on to the replacement fluid, you select the replacement fluid based on the case that you are doing it. Okay. If the patient is having high chances of having coagulopathy and having coagulation disturbances afterwards, then you can replace it with plasma. But as the plasma is autologous organ, actually, not autologous, basically exogenous organ, but that you are going to replace it. So it is going to have its own side effects like infection, allergies that is going to be with plasma. So most of the time it is done with albumin, many a times. It is ease of storage is very high with albumin. You can store it easily, simple to administer. Then how do we calculate a volume for exchange? So to start with, we rely on two main approaches. First, the Kilcher's rule of 5, which gives us an estimate of volume per kilogram depending on the sex and body habitus and age of the patient. This is the table that we use frequently to calculate the body volume. Otherwise, to be precise, Nadler's formula can also be used, where the body height and weight is used to calculate the total blood volume. Then, once the blood volume is known, plasma volume is calculated as total blood volume multiplied by 1 minus hematocrit. This gives us an idea of total plasma volume and guides us how much volume exchange is going to be done. Next point is axis, from where we are going to do it. So two different axes have been used in clinical practice. First is like the plasma exchange accessibility is absolutely critical. The access is very critical. Venous access is needed to provide adequate blood flows and reliable return throughout the procedure. The procedure is going to be a little longer, so you can use peripheral as well as central both, but there are pros and cons related to both of them. Big advantage of the peripheral is that it is less invasive, quicker to place, carries a lower risk of line sepsis and etc. All the things are there. But the big con is there that the long plasma exchange session, it is not going to. The patient has to be very cooperative with peripheral excesses. Okay? Big needles are there going into the antecubital veins or femoral veins, and patient needs to be very stable to tolerate them for a longer time, maybe 2-3 hours of plasma exchange therapy. So what we use in our ICUs central excesses mostly, like our dialysis line, routine dialysis line, the central excess is there. The pros and cons are related to these lines are similar to whatever the usual practice we are doing with hemodialysis lines. So, apart from the lines and related complications, there can be many other complications of the plasma exchange therapy. First of all, because of massive fluid shift, hypotension can be there due to fluid shifts during the exchanges. Electrolyte imbalances can be many because you are using citrate, you are replacing plasma. The amount of electrolytes is going to be disturbed. The calcium is the most common electrolyte abnormality that is seen with the plasma exchange therapy. So we monitor it regularly after each plasma session, after 12 hours usually. Okay? Because it needs to settle down a little, it needs a little settle down time to have this. If the patient is having symptoms related to hypocalcemia during the plasma exchange, then we replace it without knowing the actual values. Then risk of infection is always there, more so if the central line access is used. Bleeding can occur because of the anticoagulation and vascular injury. Some patient may develop allergy or hypersensitivity reaction to replacement fluid. Cardiovascular issues, arrhythmias can be there, and especially with pre-existing heart disease. And apart from these major concerns, some minor side effects like fever, chills, tingling, relatively common, but manageable mostly. So the whole point is that the complications are not that much nowadays with safe critical care and other USG guided techniques we are using for the central line placement and everything, that it is not manageable. Okay? It is very safe nowadays to use plasma exchange therapies. So come back to the last case. This was very interesting case. So this female who was having phenytoin-induced toxic epidermal necrolysis, what we did with her is we started her with the plasma exchange therapy on day 3 because she was not improving and she was deteriorating rapidly after that. So this table shows that key parameters during plasma exchange were remained stable. Hemoglobin was stable throughout the cycles, the platelet was stable. We did 6 albumin replacement on day 1, 1.2 volume was exchanged, 1.5 on the second volume exchange and 1.6 on the third volume exchange. Now show the recovery, how she had. After the first cycle, no new lesions appeared to the patient. After the second cycle, the present lesions started healing and mucosal secretions were also reduced. Magical, almost magical response was there. After the third cycle, wound healing and reepithelialization was very evident. Okay. After 3 cycles of therapeutic plasma exchange and supportive care, on the day 8, the patient was shifted out of the ICU. And on day 12, after some supportive care from the neurosurgical point of view and other things, patient was discharged from the hospital in this state. She returned to us after 15 days in this state. Almost all the lesions were recovered. There was no any side effect related to the therapy or the therapies that were going on to the patient. So this was just to show that how remarkable the response can be sometimes. So this slide shows the annual trends of therapeutic plasma exchange at our institute, my institute, Mahatma Gandhi Medical College and Hospitals. Reflecting our growing clinical activity, the overall trajectory highlights strong and sustained utilization of this therapy. We are going on with the liver transplant programs and kidney transplant programs also, so that's where it is mostly used. This has been possible only through the close collaboration with our IIT colleagues. They are frequently with us for this plasma exchange therapy. And together we have established MGMST as one of the leading regional center for therapeutic plasma exchange. With these numbers, we have done for many indications like hepatic, GBS, transverse myelitis. Mostly it is done for the hepatology and related indications, like for acute liver patient and immune-incompatible liver transplant patient, ACLF-related hyperbilirubinemia, etc., etc. A lot of long list of indications were there. These 4 cases hit to my mind. This was just memory-based. Maybe some clinical details were missing in these cases, but this was the end point that we wanted to conclude. So this is going into the global projection of this therapeutic plasma exchange. As the technology is going to penetrate more and more, it is predicted that by the end of 2034, the use of plasma exchange will multiply by 2 times by what we are having now in our vision. especially Asia Pacific region, India, China, Korea, Malaysia are triggering this growth because we are having more and more penetration of the technology with therapeutic plasma exchange. So the key takeaways from my point, indications are expanding. We need to keep our eyes open. Physiological plausibility, improved safety with modern tools is there. So we do not hesitate nowadays to use therapeutic plasma exchange wherever it is indicated. It is cost effective versus IVIG therapies. Many cases we have seen IVIG can go into lakhs and something, but at our center, therapeutic plasma exchange cost about like 20,000 or so per session. It is rising global demands is there, which is projecting that high use of therapeutic plasma exchange is going to be there in future. Broad clinical applications are there, but we have to use a sound rationale before using it, okay? Because it is actually an invasive therapy. We are using some other patients' plasma also to replace sometimes. So we need to be very clear. At this point, I would say that we are not recommending it so far. We have not done any case for sepsis so far, so I'm not very sure about sepsis. Sepsis is basically a different case where pro-inflammatory and anti-inflammatory, both the things are going on. If you remove the plasma part, then pro-inflammatory and anti-inflammatory, both the things will be gone. Okay, so it is not going to be clinically effective, and so has been replicated in many clinical trials also. So with this, I would like to end over here. So I have no conflict of interest to declare. This is our blood center. We are using now plasma exchange for many rarer disorders also, and our blood center is now American Society recognized also. So with this note, thank you so much.
Thank you, Dr. Ravi, for your crisp insights into this plasma exchange. As we are running short of time, we'll have discussions during a lunch break. We now invite our next speaker, Dr. Amit Mehta, who is Consultant Critical Care.
So, thank you, Dr. Kishore and Dr. Ravi. It was really insightful lectures. So, to felicitate our speakers and chairperson, I would request Dr. Gitesh Mangal, Director Critical Care, Hope Apex Hospital, Jaipur, to come on stage, please. I would request Dr. Kishore Mangal to come for the felicitations. So, sir, Dr. Ravi, please come on stage for the presentation. Dr. Arun, please. Thank you, Arun sir. Thank you, Pritesh sir. So quickly we'll start the third session. For that, I would request Dr. Vipul Khandelwal, Director Internal Medicine and Medical Director, Apex Hospital, Jaipur, as a chairperson, to come on stage. Dr. Shubhkaran Sharma, HOD Critical Care, Gitanjali Medical College and Hospital, Jaipur. Please come, sir. Dr. C.S. Gaur, Consultant Critical Care, SDMH, Jaipur, and Treasurer, ISCCM, Jaipur. Please come on stage. I would request chairperson to introduce speaker and start the session.
I request Dr. Vinod Kumar Singh sir. He is a brilliant and expert in field. No need to any introduction. Start, sir.
First of all, good morning to all of you. Good afternoon, and my sincere thanks to Dr. Vijay and all the members of the organizing committee to invite me. And actually, it is very nice to see that the topic you have selected for this conference, because how the critical care is growing now. If we talk about 10 years back, we are talking about central line, ventilator, and all those things. Now we are talking about the extracorporeal support. So new generation of intensivists, they are trying to talk about the definitive treatments. They are trying to talk about those things which are done previously by other people, because now we think that these are the things who are going to have impact on the survival on those patients who are admitted to the patient to the ICU, and we are getting more and more keen, and we are taking more and more accountability for treating extracorporeal patients who are critically ill. So this time when we are talking about the next extracorporeal therapy, that is the CRRT, which is probably the most commonly used extracorporeal treatment in ICU. What I'm going to talk about is some of the concepts and the principle of CRRT and the indications and initiation and what is some of the troubleshooting. So it is a technique which is a prolonged RRT, prolonged respiratory support. And if you look at the data, it says that whatever the controversy exists in the CRRT, to go CRRT, to go SLED or EMO, most of the time, 75% of the RRT-based treatment is going in the intensive care unit. And this all three types, whether we are going for CVVH or going for CVVHD, but most commonly what most of the U and we are doing is the CVVHDF, that is the diafiltration. Now, because my topic is how to prescribe the CRRT, so let us start a case with a person named Mrs. Roy, who is a 58-year-old woman, 80 kg, with a medical history of hypertension, and who was transferred to the tertiary care hospital for extracorporeal support, that is the ECMO support for the acute respiratory failure. Already we have discussed about what are the indications for ECMO support, and as she has got a severe form of ARDS in multiple ground glass capacity in the lung, and 24 hours after the ECMO canalization and putting on the ECMO, she became oligotic and developed acute kidney injury. And she had anemic for 12 hours despite the high dose of diabetic challenge. And the admission sodium was 133, and the patient was actually going down in terms of the AKI. And so the CRRT started when the patient has got almost 15 liters of positive balance. As we know that when you put the patient in ECMO, you give more and more fluid to those patients to maintain the flow. So C was a 15 liter, C had a 15 liter positive balance, and C was an ordered infusion. Vasopressin was short. BUN was almost 110 and creat was 3 and lactate was rising with 6. So this is one of the complex scenarios where you have put the patient on extracorporeal support and you are trying to go for a second extracorporeal support. So probably these are one of the sickest patients in the ICU, and actually it is going to utilize all your experience, all your knowledge regarding the extracorporeal support. Anyway, so if you look about the renal replacement therapy, we have the intermittent hemodialysis. We can have a continuous, that could be CVVH, CVVHD, that is hemodiafiltration, and CVVHDF, hemodiafiltration. We'll have a hybrid mode which we use in ICU, SLED, EDD, that is extended dialysis, and sometimes SIFT we are using in our patients also. So these are the different modalities, and the selection of the modality depends upon at what type of critical illness your patient is having. And if you look at this, what we are talking about, the hemofiltration, hemodiafiltration, and hemodialysis, there is a difference between the solid clearance. Somewhere, like the hemofiltration, we are using a concentration gradient, and hemodialysis also, we are getting to a concentration gradient. Sometimes we are going for a diffusion. But hemodiafiltration, you combine the diffusion as well as the convection to have the greater solid clearance and the fluid clearance. So, if you look at the CRRT, why it is different from the other type of RRT? Because of the three things. It uses the diffusion, convection, and sometimes adsorption also for the solid clearance. And also, we are doing an ultrafiltration in CRRT patients. So, if you look at the indications, who are the patients who actually fit for the CRRT? Those who requires RRT, who are the subgroup of patients who should go for CRRT, the most common is those who are hemodynamically unstable, those who are requiring vasopressor support, a low cardiac output status or a high cardiac output status but high vasopressor support. Patients who are in severe fluid overload, unresponsive to diuretics, a patient who has got hypercatabolic state or trauma, a high fluid requirement because of the other factors also, and those patients who are getting the extracorporeal support but requires RRT also, these patients are actually fitting the criteria for CRRT. And there are certain less established criteria, like patient who has got a lactic acidosis, ARDS patient, those patients who has got congestive heart failure, or those patients with congestive heart failure with renal failure. These are the patients where we can also go for continuous renal replacement. Now, if you look at the critical guideline, which says that who are the patients who is fitting for renal replacement therapy. So it can be divided whether the patient is acutely needed any support, and if it is required, like if the patient has got a hyperkalemia with the potassium of more than 6.5 or EKG changes, and the signs of refractory medical treatment which we are giving to the patient. The second is severe form of metabolic acidosis, pH has gone down to less than 7.15, and the patient has got a fluid overload leading to manifestations of the fluid overload, pulmonary edema and other things, which is refractory to the diuretic. Probably these patients require immediate renal replacement therapy, and if they are fitting in the CRRT criteria, they should go for a CRRT. Otherwise, because of the lot of controversial data, whether to go for an early RRT or go for late RRT, so the people have actually adopted a middle path, that is, observe the patient for 8 hours, and if you find that the patient is deteriorating, then you should go for RRT in such patients. This is called a delayed RRT sometime also, or interval RRT. Actually, we are supposed to monitor the patient. If the patient is not improving in terms of urine output and AKI, then you should go for renal replacement therapy in such patients. Or if you find that the BUN has gone more than 100 12 milligram per dl, then you can go for RRT in such patients. So basically, whatever the modality you are choosing for the RRT, it is better to divide it into acute and the interval or the delayed RRT, and depending upon the parameters which is being used by the critical guidelines. Now, what is the advantage of CRRT over other renal replacement therapy? Like it can cause removal of the waste product, restore the acid-base balance, which is the most important advantage of this renal replacement therapy, and correct the electrolytes abnormality, hemodynamic stabilization. More than that, it actually prevents the deterioration of the hemodynamics in those patients who are on vasopressors. Also have a great impact on the fluid balance because it is a prolonged treatment, and sometimes removal of some of the mediators by the mechanism we call it adsorption, which occurs in CRRT patients. So our patient who has got a multi-organ failure, including the respiratory failure, shock, and patient had anemic AKI. In addition to evolving the fluid overload, the patient have a high predicted mortality because of the high amount of the fluid overload. For the patient who actually added to the ECMO, the RRT for starting not only for the AKI but also for the removal of the fluid in such type of patients. So what type of prescription we are looking in our patient cannot go by this. So if you try to compare, or we have discussed with you that where the first stops for the CRRT, if you look at the things, patients' hemodynamic instability, fluid overload, acute intracranial injury or hypertension, or life-threatening condition. So if we look at the life-threatening condition, of course, if the patient has got a hyperkalemia, our first line is IST, intermittent hemodialysis, not the CRRT if the patient is fitting for the IST criteria. But most of the time in ICU, most of the beneficial effect we are finding in putting the patient on the CRRT, if you look at this table, and that's why the critical guidelines also says that if the patient is actually meeting the criteria for renal replacement therapy, the CRRT is the better option than other forms of renal replacement therapy in such patients. So as we discussed that what are the modalities of this continuous renal replacement therapy, we can have a SCUF where we are mainly looking for a slow and continuous ultrafiltration. We are not going for any dialysis. We are not going for any fluid replacement in such patients. We just go with the ultrafiltration in such patients, and mainly used for pulmonary edema patients where we can use this SCUF. Not used nowadays much, but it is one of the modality for such type of patient. The other is CVVH, where you use mainly you are doing a hemofiltration, and that produces a convective clearance of the solute, as well as sometimes also it clears the ultrafiltration also, and you use a replacement fluid besides, and we are not using any form of dialysis here. CVVHD and CVVHDF. If you talk about between these two, mostly in the intensive care unit, we are using a CVVHDF, that is diafiltration. The basic difference is that we are using the replacement fluid as well as we are using the dialysate. That's HDF, hemodiafiltration. While in HD, we are using dialysate and we are not using the replacement fluid. So we'll come to know why we use some patient replacement fluid and we are not using some in some patient replacement fluid. But at this stage, try to understand, most of the time when you prescribe the CRRT, we are using HDF, that is CVVHDF. That means we are using a dialyzer, which also, and also you are using a replacement fluid in such patients. Now the question is that any benefit among choosing this modality? So that depends upon your machine, that depends upon your expertise, that depends upon how you are acquainted with those type of machines, and there is no benefit of there is no any survival benefit, but most of the time we are choosing this CVV HDF. Now look at the configuration. When you are using a HDF modality, if you look at the green one, which is a dialysate flow is going, and it is going to the dialyzer, and there, if you look at there is an excess line and there is a return line, and you can see that there is a replacement fluid. That's how the configuration of the HDF, where we are using, and this return fluid can be either a pre-filter and can be a post-filter depending upon your choice. Many times we are using half of the replacement fluid pre-filter and half of the replacement fluid post-filter. So all CRRT techniques other than SCUF requires the use of sterile dialysate and replacement fluid, and mostly it is used to facilitate the actually solute movement in such type of machines. Now coming to what prescription we are trying to do to our staff or those who are doing the CRRT, because even the technicians who are going to do the CRRT, you need to give some instructions like how much the blood flow will be, what should be the duration of the RRT, what should be the ultrafiltration, what should be the dialysate flow, and what should be the replacement flow. Usually we keep blood flow around 80 to 200 ml per minute in patients with CRRT. We keep the duration for 24 hours, many times it can be extended to 48 hours. The ultrafiltration could be 2200 ml per hour of the total volume. We have to use anticoagulation, dialysate 600 to 1800 ml per hour. You can go up to 3 liters depending upon the condition, and replacement fluid almost 1000 to 2000 ml, that is 1 to 2 liters per hour it can be used in such type of patients. Now the question arises whether to use replacement fluid and the pre-replacement, that means before the dialyzer or after the dialyzer or after the blood pump. Both has got advantage and disadvantage. If you are using the pre-replacement fluid or pre-filter fluid, there will be blood will be diluted because the fluid were given to the pre-replacement area, and there will be more decrease in the acidity in the hematocrit. And if you are giving the post area, that will be blood will be more and more concentrated, and there will be rise in the hematocrit. So there is no confusion nowadays to give pre or the post. Most of the time, most of the machines are coming, half of the fluid we can give pre and half of the replacement fluid we can give the post dialyzer area. So how to calculate the replacement fluid? How much replacement fluid I have to give? The replacement fluid weight is continuous RRTs are almost around 20 to 25 ml per kg per hour, as it is recommended by the category. But according to the patient's need, you can modify. If you need more and more solute clearance, you can actually increase, but mostly it is upper limit is 30 ml per kg per hour. We will come to know what conditions we are going to have more and more replacement fluid. And what we do is 1400, it will go for 700 to pre and the 700 to post replacement fluid area. Now what is filtration fraction? That is very important. The filtration fraction is that how likely the filter is going to clog. Now try to understand. If you go more and more ultrafiltration, what will happen? There is more and more rise in the hematocrit value, because more and more plasma is going down. So a rise in the filtration factor can cause more and more clotting of the membrane. And this is one of the mechanisms how we can avoid the filtration factor. If we compare with the ECMO, we do not have any mechanism which can say that our ECMO is going to be clotted. We have, because ACT we are measuring, and if you keep the ACTs at some level, you can say that but here we are concentrating, we are removing the fluid. So if the filtration fraction is going to be more than 20 to 30%, there is more chance that your RRT filtration or RRT is going to be clotted. Why we are worried about the circuit itself causes 50,000 for the patient. So we try to avoid the anything which can cause clogging or the clotting of the circuit. That's why one of the criteria to keep the filtration fraction around 20 to 30% to prevent the filtration fraction clotting. And how to calculate it is that you have to go for a ultrafiltration and go for a plasma flow, and you can calculate it filtration fraction by 100 into ultrafiltration divided by the plasma flow into 0.95 plus free flow, how much you are giving. This you don't have to calculate. The machine itself gives you that this is your filtration fraction. So you have to actually manipulate the ultrafiltration, and you have to manipulate the pre or post filter fluid to prevent the filtration fraction going on or high. So this is how the sometimes you can see the machine. Our patient, if you can look at the patient has got a ECMO as well as the CRRT is going on this. One is not moving. Okay, so you can see here you don't have to calibrate the patient because the CRRT circuit is placed in the some of the area in the ECMO circuit, and where to place the CRRT in the ECMO circuit is that you don't have to go the post-oxygenator. Nothing should be placed post-oxygenator in ECMO. So what we do, we take the blood from the pre-pump and you can deliver the blood to the post-pump area. Or even you can take the blood from the post-pump and deliver to the post-pump area. So whenever you have such a complex extracorporeal support, when we are trying to use the ECMO as well as CRRT, it is very challenging to maintain those two circuits because of there is more and more chance of complication. The first thing is that we are not going to touch the post-oxygenated area because there is more chance of embolitis and there is more chance of clotting. So when we are connecting the machines, when you don't have to put another line because the low patient is in heparin. So at this stage we cannot put any other line or any dialysis catheter for patient. So this option is out in those patients who are already on ECMO. But yes, if your patient already had a dialysis catheter, you can even connect with the dialysis catheter and you cannot and you avoid touching with the ECMO lines. But most of the time there is no dialysis catheter, so we have to put the CRRT circuit in the ECMO, and either you take the blood from the pre-pump area and go supply to the post-pump, and you take the pre-pump and go post-pump, and then you will supply to the post-pump area. But yes, if you don't have or your patient is not in ECMO, the first thing is that you put the dialysis catheter, and you don't need to talk from my side how to put the dialysis catheter. Every intensivist knows that what should be selected and where to put. We do not put in the subclavian area dialysis catheter because very high chance of subclavian stenosis. Either you go for an IVC or you go for a femoral line. We avoid, and actually we are not putting any dialysis catheter in the subclavian area. This is a new Baxter machine which we are using nowadays, and this will give you all over the data, whatever the setting, and actually even if you are not much trained in the dialysis, if you are going with the flow with the machine, you can find out what we have to do, what setting we have to do, and you can see that the 4 bags which are there, that will be related to the dialysis, pre-fluid, post-fluid, and the total effluent which is coming. And then you can see the dialyzer and all those things which are there in this CRRT machine. So if you're going for a quick start for the patient who is actually having requiring CRRT, a 70 kg adult patient, you can keep a blood flow of around 150 ml per minute. You go for a effluent 1750 ml, that is 25 ml per kg per hour, and then dialysate 1000, replacement 750, ultrafiltration goal. Select with the 50 ml per hour, you can go up to the 100 ml per hour. If you look at the effluent, if you look at here carefully, the effluent is 1750. From where it has come? It has come from the dialysis, dialysate flow 1000 and the replacement 750. So that's how the effluent. And if you aid the ultrafiltration, that will be the total effluent is coming to your collection area which is there in the effluent area. And then what to monitor? Most of the time, 6 to 8 hours, you are monitoring the sodium, potassium, magnesium, You go for acid base status, calcium, if you are patient with citrate anticoagulation, and then you should watch for the hyponatremia and hypothermia because you have aided extracorporeal circulation. And now CRRT are coming with the temperature management system, so you can have a better temperature management system. Now, how to decide the dose of the CRRT, how much CRRT dose, and what is the meaning of the CRRT dose? The CRRT dose is recommended the minimum effluent, which is around 20 to 25 ml per kg per hour. That's what we are targeting as an effluent coming to the CRRT machine. And we can calculate, actually your machine can calculate the dose, and what we have to be careful is that more and more higher doses are not going to help to the patient. There are many studies which has compared the low dose and high dose, and they have found that most of the time in routine practice 20 to 25 ml per kg body weight per hour is okay, except in certain situations where the patient has got an abdominolysis, the patient has got a hyperammonemia, the patient has got a liver failure, and they are using a CRRT. But there you can go up to the 50 ml per kg per hour. But these are the exceptional situations. They are not the routine management and recalculation of the dose of the CRRT. Now, as you know that the major work of the CRRT is fluid management and the fluid management. So, patient fluid balance will be taken care. And when you talk about the patient fluid balance in CRRT, actually it is different from the other RRT, because here, whatever the input you are going to give to the machine and output, and whatever the input to the patient and the output, then we'll be able to find out actually what is going to happen to the patient's fluid balance. You have to calculate both the machines and the patients. Now, in clinical practice, the dose of RRT is the effluent flow. As I told you that 20 to 25 ml is coming as effluent, then we are okay with the CRRT function. And the typical dose, 25 to 35 ml per kg. Why it is necessary to give slightly higher dose? Because many times you have to interrupt the CRRT. So if you take into account of 20 to 35, then actually it is going to have 20 to 25 ml per kg body weight. You have to interrupt for the circuit change, you have to interrupt for the patient who is going for investigations. So what we have found that in 24-hour CRRT, maybe many times you are going to interrupt for 2 to 3 hours. So accordingly, we have to go in for adjustment of the dose in those patients where we are going to. And as I told you that if the patient has got a hyperammonemia, the patient has got an abdominolysis, we have to go, or we can increase the dose up to the 50 ml per kg per hour in such cases. Now, I will discuss that patient who has got required higher doses, we can go for that. But in one situation where the patient has got a hyperkalemia, because CRRT is slow dialysis, if the patient has got a life-threatening hyperkalemia, what to do? Because if you go with these situations, the patient is not going to have outcome. So what you do is that you can go for a higher doses, like you increase the dialysate flow, you increase the replacement fluid flow, and you can increase the blood flow up to 200 ml, and that way we can actually going to correct the hyperkalemia in such cases. So hyperkalemia CRRT is not the treatment of choice, but patient who has got a severe hypertension, hemodynamic compromise, increasing the dose and increasing the effluent by increasing the dialysate flow up to the 2000 ml and the blood flow up to the going for 200 ml, you can actually correct the hyperkalemia in such cases. So what is the net ultrafiltration? That is also we have to find out that the significant heterogeneity exists when we talk about net ultrafiltration, but mostly 1.5 to 2 ml per kg per hour is the sufficient. Like if you are doing a CRRT patient who has got a 60 kg or 70 kg, you can target ultrafiltration is 120 ml per hour. We start with the 50 or 25 ml per hour, gradually go up to the 100 and 125, or that is your target, where you can more and more ultrafiltration causes more and more clotting of the circuit and more hemodynamic problem with the patients. So targeting 1.5 to 2 is just sufficient to achieve your target for fluid balance in such patients. Now, because we have to use anticoagulant in such patients, and what should be anticoagulation strategy? Many times your patient is severe coagulopathy, low platelet count, patient has got higher PT, higher APTT. In these situations, you do not go and you should not target any form of anticoagulation in such patients because there is a high chance of bleeding. Now, if you are using in those patients where there is no contraindication to use the anticoagulant, you can go for heparin infusion, and it should be around 5 to 10 units per kg per hour, and targeting APTT of 1.5 and ACT of 180 to 220 seconds, that will be sufficient, and should monitor also. Regional citrate is being used. We have used in many patients, but actually it is too costly to use in CRT patients, and a lot of complications like if you have more and more alkalosis, hypocalcemia, and need more and more monitoring in such patients, and prostacyclin is not available here. So we left with the either no anticoagulation or using heparin and monitoring ACT in such patients. Already we have discussed about the drug management in CRRT and bleeding, that we have to stop all the anticoagulation. Now, many times when we are using in CRRT and using patients, the machine starts alarming, and you will be bewildered what to do now, whom to call for such patients. So, if you are using, your ICU using CRRT, so you must aware all the alarms which can stop the CRRT, or which can stop the functioning, or which can clamp the circuit also, because there are alarms which can stop the pump. There are alarms which will not stop the pump, but we have to correct it to go for further. So we should be must aware about what are the alarms for the CRRT, and there are certain principles. Always check the patient first in cases of alarm, and inspect the line when the line is kicking or something happening in the line, and also consider the volume status of the patient. Patient is hypovolemic, then you have the alarm, and whatever the things are there, you should document for all this. So if you look at the alarm which you can have for a patient, one is the excess pressure, because you have more and more negative excess pressure. If it is more than 150, it will start alarming. Then you will have a return pressure. If you have more and more high return pressure, that indicates a very high pressure in the return cannula, and then again your alarm will start. Then you will have the filtration pressure alarm, and then you have the effluent pressure alarm. So excess pressure alarm and the filtration and pressure alarm and the return pressure alarm, they are, if you not deal with these alarms, they will have alarming for some time, and then your blood pump will going to stop. So once the blood pump is going to stop, the whole circuit is going to be clotted, and then you have to change the circuit also. So what to do if you have an excess pressure alarm, and don't be panic. We should check how much flow is going on, where is the problem is the catheter, is there kinking, is there clotting, or there is a hypovolemia, and then you should just neutralize the alarm and restart the machine. If you have corrected the things, the machine will restart. The similar things will be applicable to return pressure. If it is going more than 250, the machine will start alarming, and then again you have to see whether the return pressure is going to be return cannula in somewhere is clotting or somewhere is going to be kinked. Then you have to correct it, and then you stop, and then you can start it again. Now TMP is very important. TMP is the transmembrane pressure alarm, and this says that your membrane is going to be die out in some time, and if actually it has gone to more than 300, that means either there is a very high SCT in the membrane area and more ultrafiltration, and the membrane has got clogged, or the membrane is dying and the membrane has got clotted. So you have to change the whole circuit, and then you have to optimize the anticoagulation. You have to optimize the ultrafiltration to prevent the TMP going more than 300 to 350 SI. So this is again some problem to feel. Okay, so if you look at these, all the alarms you can see here. Upper one, this is the axis pressure alarm, and then you have the second one is the return pressure, and then the filtration pressure alarm, then you have the TMP alarm. So you should have a look on all these alarms, and if you have a problem, you can manage it. So to summarize our prescription of CRRT, the mode we have selected in our patient who are an ECMO and vasopressor support is the CVVHDF, that is hemodiafiltration, that is convection, also filtration and diffusion. The dialysate fluid started with the 2000 ml per hour. We have a margin to start from 1000 to 2000 ml per hour, that is the dialysate fluid. The pre-blood pump we started around 1000 ml per hour, that is the pre-filter, you can say. The post-filter fluid is started with 1000, so total is 2000 ml per hour, that is the replacement fluid. And the net ultrafiltrate goal of what we set was around 50 ml per hour. So the net negative balance, whatever the machine and whatever the patient you calculate, the net negative balance is going to be 50 ml per hour. So maybe around, if you calculate around 24 hours, so it will be 500 in 10 hours, then 500, and then maybe 1.5 liter it is going to be. And then the solution composition, it is nowadays it is coming with the machine, so you have not to worry about. We have to select a bicarbonate fluid, we selected the bicarbonate fluid. So then that's how you prescribe the patients, and that's how you effluent dose. If you find the effluent dose here, you can also calculate the calculation, the 2000 and plus 50 ml and plus 2000 ml, that should be effluent dose. And that is also the dialysis dose or CRRT dose to our patients. So with this, I will stop here. If you have any questions, we will talk. Thank you.
Many thanks, sir. Over to the audience. Anybody want to take any questions? Because we will conclude the session as we are already running short.
Thank you.
Excellent lecture, sir. So we are really grateful that you have accepted our invitation to come to the Impact 2025. For this felicitation of Dr. Vinod sir and our chairperson, I would request Dr. B.M. Goyal sir. He is the director of Cardiology Department, Apex Hospital, Jaipur. Please come on stage, sir. I would request Dr. Vinod K. Singh sir to come for the felicitation, sir. We will also felicitate our chairperson, Dr. Vipul sir. Please come. Dr. Shukran sir. Dr. C.S. Boy sir. it's a time for the formal inauguration of the ceremony. The lamp is a symbol of clarity in complexity. It's a symbol of light in critical moments and our collective commitment to advancing care for critically ill patients. As we light this lamp, we ignite a shared purpose to explore, to innovate, and to serve our patients better. So for lamp lighting ceremony, I would like to invite Dr. S.B. Jawar sir, Chairman of the Apex Hospitals. Please, sir. Please come. I would also request Dr. Vinod K. Singh sir to come for the lamp lighting. Dr. Venkat Goyal sir, I would request Dr. Venkat to come also. Dr. Mohit Roy, Chairperson ISCCM Jaipur, please come sir. Dr. Nikhil Ajmera, Secretary ISCCM Jaipur, please come. Dr. S.P. Sharma sir, please come sir. Dr. M.L. Gupta sir, please come. And Dr. Priya Makhanda. Thank you so much everyone. Please take a seat. So on behalf of Apex Hospitals, I would request Dr. S.B. Jawar sir to say a few words about the today's program.
Respected senior faculty members on the dais and off the dais, speakers who have come from across the country, executive committee members of Jaipur, ISCCM, and dear delegates. I welcome you all on behalf of Apex Hospital for this critical care event, Impact. Critical care is the backbone of any healthcare institution of the repute. As you all know, Impact is an annual critical care event hosted by Apex Hospital in association with ISCCM Jaipur branch. Apex Hospital is one of the fastest growing multi-specialty hospital chain of Rajasthan. Currently, we have 7 centers across the Rajasthan. Critical care is very close to our heart, and we ensure to have all high-end equipment and excellent team who can perform all latest procedures for our critical care patients. This year, the theme for the conference is extracorporeal therapies in ICU. I assure you will have a wonderful academic fest attending today's program. I'm happy to share that we have more than 200 registrations for today's event. Please actively participate in all sessions and try to learn the maximum from our national level faculty. Further, we shall be continuing this event every year with different themes. Once again, extending a warm welcome to all. Thank you very much.
Thank you so much, sir. Now I would request Dr. Nikhil Ajmera, Secretary ISCCM Jaipur, to give introductory speech for this event.
Very good afternoon to everyone. On behalf of ISCCM Jaipur, I, Dr. Nikhil Ajmera, Secretary Jaipur branch of ISCCM, is thankful to Apex Hospital for giving us the opportunity to connect with them for this academic extravaganza. Thanks to Dr. S.B. Jhamar sir, Dr. Sachin, Dr. Shailesh, the management team of Apex Hospitals. Our speakers, renowned speakers, Dr. Venkat Goyal sir, Dr. V. Vinod K. Singh sir, Dr. Yash Javeri, and our own local faculty to be the part of this academic feast. Friends, I am really happy to share that this year we are celebrating 25 glorious years of ISCCM Jaipur. So it was founded in the year 2000 and it's 2025. So this is the 25th year celebration actually for Jaipur ISCCM. Claps for that. Thank you. Last year's Raj Criticon was a huge success. We all know that, and it became possible because of the involvement of selfless, dedicated, and enthusiastic members of ISCCM Jaipur. So a big round of applause for ISCCM Jaipur members also for making that event successful, which was organized after a long gap of around 10 years. Now this year we are organizing Jaipur Criticon. We are organizing this Jaipur Criticon in the month of November. 1st and 2nd November are the conference dates, and 31st October is the workshops at 6 different hospitals. So I request all of you to get registered ASAP and be a part of our own conference. Regarding the academic programs by Jaipur ISCCM, we organized one CME with the Jaipur Medical Association this month only on ARDS, on the World ARDS Day, and it was a huge success. It was attended by more than 150 delegates there. We have also started a webinar case-based series by Jaipur branch of ISCCM that is happening on every last Saturday of the month. And yesterday only we had the second session of that webinar case series. For the upcoming World Sepsis Day, I request all of you to organize a small awareness program in your own hospital for the general public to get aware about sepsis, because sepsis, is the main core of any critical care, any ICU care. So, and also I request you to share the pics of that also with us. You will also glad to know that ISCCM Jaipur is now getting recognition at the national level. We are getting recognition at the national level. But friends, we really need to work hard to get the best upcoming branch award for the forthcoming national conference. So I request all of you to do something for that also. At last but not the least, with continued rigorous effort by all of us, we will surely get a chance to organize a national conference in Jaipur in near future. So, Jaipur ICCM needs the blessings from all of you. Thank you very much and best wishes for this CM. Thank you so much. Thank you.
So I request Dr. Vipul sir to felicitate.
Get registered for Jaipur Criticare and also for the National Conference Criticare 2026 in Chennai. Thank you.
So now we are moving ahead with a very special ceremony. So for that I would request Dr. Hitesh Mangal, Director Critical Care of Apex Hospital, to take us to that special one.
आदरणीय अतिथिगण, वरिष्ठ सहयोगी एवं यहाँ उपस्थित सभी साथी, मैं डॉक्टर हितेश मंगल एपेक्स परिवार की ओर से इस विशिष्ट सम्मान समारोह में आप सभी का हार्दिक अभिनंदन करता हूँ। आज का यह अवसर अत्यंत ही विशेष है क्योंकि हम सभी ऐसी महान विभूतियों का सम्मान करने के लिए एकत्रित हुए हैं जिन्होंने अपना संपूर्ण जीवन चिकित्सा सेवा, शिक्षा एवं मानवता के कल्याण हेतु समर्पित कर दिया है। इस सम्मान समारोह के लिए मैं हमारे समक्ष उपस्थित विशेष अतिथिगण को मंच पर आमंत्रित करना चाहता हूँ। सर्वप्रथम डॉक्टर एस.बी. झवर साहब, चेयरमैन एपेक्स ग्रुप ऑफ हॉस्पिटल्स। डॉक्टर विपुल खंडेलवाल सर, मेडिकल डायरेक्टर एपेक्स हॉस्पिटल। डॉक्टर मोहित रॉय सर, चेयरपर्सन ISCCM जयपुर। सर, मैं आप तीनों से आग्रह करता हूं कि मंच पर पधार कर अपना स्थान ग्रहण करें। अब मैं मंच पर आमंत्रित करना चाहता हूं उन आदरणीय गुरुजनों को जिनके लिए यह समारोह आयोजित किया गया है। डॉक्टर M.L. गुप्ता सर, डॉक्टर S.P. शर्मा सर, आपसे अनुरोध है कृपया अपना स्थान लें। डॉक्टर एम एल गुप्ता साहब ने पल्मोनरी एवं क्रिटिकल केयर मेडिसिन के क्षेत्र में उत्कृष्ट योगदान दिया है। आपके अथक परिश्रम और दूरदृष्टि ने न केवल गंभीर रूप से बीमार मरीजों को नई जीवन आशा प्रदान की है, बल्कि चिकित्सा विज्ञान की प्रगति में भी अमूल्य योगदान दिया है। आपने केवल रोगियों का उपचार ही नहीं किया है, अपितु भावी चिकित्सकों की पीढ़ी को भी मार्गदर्शन दिया एवं उन्हें ईमानदारी, संवेदनशीलता और समर्पण का वास्तविक अर्थ सिखाया। आप हम सबके लिए प्रेरणा स्रोत हैं और आपकी कार्यशैली आने वाले समय तक हम सभी का प्रदर्शन करती रहेगी। मैं एम एल गुप्ता साहब से अनुरोध करूंगा कि वो आगे स्थान ग्रहण करें ताकि हम उनका सम्मान भी करें। मैं एस पी झवर साहब से रिक्वेस्ट करूंगा कि वे शॉल उड़ाकर और साफा पहनाकर सर का अभिवादन करें। गुरु गोविंद हो खड़े काके लागों पाए, बलिहारी गुरु आपने गोविंद यो बताए। अब मैं आमंत्रित करता हूं डॉक्टर एस पी शर्मा साहब को, जो न केवल एक आदर्श चिकित्सक के रूप में अनगिनत मरीजों की सेवा की, अपितु एक गुरु के रूप में अनेकों विद्यार्थियों का मार्गदर्शन भी किया। व्यक्तिगत रूप से सर, मैं आपके सहज, सहनशील एवं संवेदनशील व्यक्तित्व से अत्यंत प्रभावित हुआ। जब भी मस्तिष्क पटल पर शंका के बादल गहराए, आपने पार्थसारथी श्री कृष्ण की भांति मेरा मार्गदर्शन किया व जीवन में सही दिशा दिखाई। मैं डॉक्टर एस पी झवर साहब से रिक्वेस्ट करूंगा कि सर का सम्मान करें। अब मैं डॉक्टर एम एल गुप्ता सर से आग्रह करता हूं कि वे यहाँ उपस्थित सभागण को संबोधित करें।
Dear colleagues, I was not knowing that I will ask to speak. And first of all, that I convey my heartfelt thanks to the organizers for inviting me and giving me this honor. And I have very superficial relation to the critical care. I am not directly involved with critical care, but really that is the part of the medical management nowadays, very essential part of the critical care. And I hope such events will definitely help in the better management of all the patients like this. And once again, if I say that for my career building, Apex Hospital has a big role. Initially, even I was in service, I used to come as a visiting consultant there many times. And that has given me a great learning because at that time I was working as a chest physician was in a limited field whereas practice in the hospital, the general hospital was lacking there. And that gave me a great learning also. So I thanks for that also to you. And once again I thanks the organizers, Dr. Jawahar, for considering me, inviting me and felicitating. Thank you. Thank you.
अब मैं डॉक्टर एसपी शर्मा सर से अनुरोध करूंगा कि वे हम सब के लिए कुछ प्रेरणादायी शब्द कहें।
Dignitaries in the mask, of the mask, and dear friends. Basically, first of all, I would like to convey my sincere thanks to the Apex Hospital Group that they have invited me and me. And what I would like to say here, this Apex Hospital is regularly organizing a educational activity every year. So this is very important. The educational activity is very important in the sense that we have to, for the growth of ours, we have to learn latest things. So this is, thank you very much, Dr. Jawahar. So I congratulate to the team of this organizing this Impact AMA program that they have done a lot of work. And especially I will say that to all my dear colleagues here, I can see some of the students of mine, and nothing can be more pleasurable or proud feeling that your students are doing wonderful job, even better than you. Whatever we have taught them, whatever we have asked them to learn them, they are doing much more better. And here I would like to say one thing more, that always and always see for the change, what change is happening in the for education, and try to adapt it. This is important. Whatever we have seen, and in our eyes we can see that this ICU means critical care was in infantile stage, and now it has gone to such a level that new things are coming. So I personally wish everyone to learn more and more, to go and have update knowledge so that they can do some better to the human being, and it will be a great job. Thank you to everybody.
सर, आप दोनों का कोटि धन्यवाद। अंत में मैं संपूर्ण एपेक्स परिवार की ओर से ईश्वर से प्रार्थना करता हूं कि आपको उत्तम स्वास्थ्य व दीर्घायु प्रदान करें। थैंक यू सर।
Thank you so much, everyone. So now it's a time for well-awaited the keynote lecture. For that, I would request Chairperson, Dr. Pankaj Anand, Director, Internal Medicine and Critical Care, Fortis Hospital, Jaipur. Please come on stage, sir. Dr. Vijayan Solanki, Senior Consultant, Department of Pulmonary Medicine, Apex Hospital, Jaipur. Please come on stage, sir. And Dr. Mohit Roy, Professor Critical Care and Chairperson ISCCM Jaipur. Please come on stage, sir. Now I would request Chairperson to introduce the speaker and start the session, please. Thank you.
Hello. I really feel privileged to introduce Dr. Venkat Goyal. Dr. Venkat Goyal, I would say he and Dr. Pranay Ojha are the synonyms of extracorporeal therapy, at least in India. With 33 years of experience of sirs, and personally I have been witness to his expertise. More than expertise, what I found with Dr. Venkat Goyal has been his attitude of hand-holding. You know, when now ECMO is a household name, at least in critical care, but over the last 10 years, I would say around 8 or 10 years back, when we had just started hearing about ECMO, the team of Riddhi Vinayak, probably, if I'm not wrong, was the first who, gave you their numbers, and they said, if you have a patient on ECMO, we are here. They were always ready, not just with the expertise, but any time anything went wrong at 1 a.m., he was there. So it is not just his competence, not just his knowledge, but his availability to all of us. And I would say that has brought the entire science and art of extracorporeal therapy to India where it is. We are all really happy to have you, sir. Dr. Venkat Goyal.
Respected chairpersons, seniors and comrades. I call you comrades because if critical care is the military of medical sciences, then ECMO specialists are the commandos of medical military. So if you want to do ECMO, you have to work 24/7, round the year, and 366 days in a leap year. Without that, you cannot be an ECMO specialist. That is the requirement. Now, if we say ECMO science is difficult, then you will be amazed to hear the inspiring story of people who have developed the science of ECMO over the last 50 years. The first successful case of ECMO, if it is coined from 1975, so there has been a 50-year story of the success of ECMO through a very hard-earned turmoil and success step by step. So I will be taking you rapidly through that. If you think that if you do not want to go on ventilator and you are happy with this kind of a treatment, then ECMO is much more simple. If I take you through the progress of ECMO, then a century before 1975, that I would say that from 19th century onwards, the progress of extracorporeal therapy started from just giving oxygenated blood to ischemic tissue or something, and the role of oxygenated blood and organ perfusion was the concept in early 1990s. In early 20s, there was ABO blood grouping, there was J. McLean who discovered heparin, and there was a development of an auto-injector device which could keep a dog living for 2 hours after the heart had stopped. So that was the proof of concept of extracorporeal life support therapy. These are the drawings of and the figures of those machines. Then from 1930 to 1940, the concept of ECMO in humans started. The first time Gibbon, when he found a massive pulmonary embolism patient dying in front of, a young lady dying in front of his eyes, he thought this patient could have been saved through extracorporeal oxygenation of the blood, which was not possible through the lungs. And that is how, after a turmoil of 23 years, from 1930 to 1953, where his first successful case of extracorporeal support for an ASD patient was done, he took 23 years to develop that machine. So this concept of ECMO in humans started way back in 1930s. Till that, it was also a pre-ECMO era. Then the introduction of cardiopulmonary bypass in 1950, because only oxygenation was not important, circulation was also important. So people were not knowing how to support both oxygenation and circulation. So there were various scientists who had worked in this era. I will focus and narrow down and zoom to the important people there on the line. So cross connectivity and cross circulation was the concept by Dr. Giri, who could do an cardiopulmonary bypass on the parents of the patient by giving the blood through the power of the heart of the parents. So these were the machines that time. These were the screen blood film, which was giving a supply of oxygen, which Gibbon used. And then there was a membrane drum. If you see this drum here, this drum had an area surface of 6 meters square, which was used in an adult patient for a VA ECMO in a motorcycle accident, but that was a successful case in 1971. Then from 1960 onwards, the improvement in cardiopulmonary bypass and other things just kept on improving. And then we found the birth of ECMO took place in 1970s. The first case was, as I said, that motorcycle accident victim who survived a VA ECMO. Then second one was the infant with the respiratory ECMO. The third was again in 1972, a post-cardiotomy shock syndrome of a congenital heart disease patient in 1972. And the final successful ECMO was through a child of Leukonym aspiration syndrome in 1975, which was given ECMO and the patient is still alive. So this is a photograph of that lady in red suit, which is now more than 50 years of age. And various components of the circuit, the oxygenator and the pump has been developing all through these stages. Then from 1980 to 1990 was the age of turmoil. Is it right? It is wrong? It is successful? It is helpful? So various trials kept on going in that period. Then what we know in India now is what was there in 2000. We are still 25 years behind the screen of the Western Hemisphere, that we do not know ECMO as much as they are advanced. So we are still at the level of stage 2000, where in India we practice ECMO as what it is. Then from modern trials and future developments, these are the various stages of ECMO which I will highlight in a focused view. Previously, people used to do a blood transfusion to cool down a madman by giving them the lamb blood. That was way back in 1692. Then Benjamin said that if you want an organ to be functioning, you perfuse it with an arterial blood. But he failed because the blood clotted. That time the heparin concept was not there. Then heparin was discovered by J. McLean in 1916. Then because of World War from 1939 to 1945, nearly 10 years there was no ECMO development. Then I said Gibbon came for the first time, thought of a extracorporeal circulation to perfuse and to oxygenate the blood if the lungs are not functioning. And these are his efforts, where an ASD patient was repaired after 23 years of hard work. This is a lady who was 10 years after the operation, and that was his machine. Then he another two patients who gave up their machine. So Mayo Clinic took up his machine and he labeled as Mayo given heart lung machine. And that machine did really good job. So the mortality dropped from 50% in 1955 to 20% in 1956 and to 10% in 1957. So this machine served more than 100 patients for heart lung machine and a heart lung machine to do an open heart surgery. Meantime, in another area, what Gibbon was using was a screen oxygenator. He used to make a thin film of blood over a wire mesh and used to just blow out oxygen over it to oxygenate the blood. Then Dr. Lilly, he came out with the concept of bubble oxygenator. He used to bubble the oxygen through the blood and oxygenate the blood directly. But that had a lot of bubbling effect and thrombogenic tendencies. Then the silicon membrane oxygenator came in 1968, where they used a plastic membrane and there was no film and no direct contact of oxygen with the blood, so therefore there was no chance of air emboldenment. Then hollow fiber oxygenator comes, which was semi-porous, which we still use in cardiopulmonary bypass these days. Then non-porous pseudo membrane oxygenator came into picture, which we now use known as PNP fibers. Now the first successful case of adult respiratory patient on a VA ECMO after a motorcycle accident was done in 1971. Then we talk about the survivor Esperanza means hope, the first neonatal ECMO survivor in 1975. And from there the story of ECMO starts. But soon after that, this is that lady thing. The VV ECMO was promoted by Hill and the VA ECMO was promoted by Rapport in 1975 and 1979. They developed this silicone oxygenator, which was like a membrane and it had no contact of blood directly with the oxygen. This is the picture of the patient of motorcycle accident. This big side of the drum is the oxygenator. This is the first patient of a post-cardiotomy shock in a congenital heart disease patient who survived in 1972. This is our Esperanza patient. And this was the ELSO organization, the Extracorporeal Life Support Organization, mainly focusing on ECMO, had a charter meeting in 1989 in Ann Arbor, Michigan. Now, if we come forward, what have we done? Then we have to divide ECMO into 3 phases or 3 stages. From 1975 to 2008 is ECMO first era. In that era, the patient was sedated, paralyzed, intubated, maintained on rest ventilator setting, had only few specialists, lung recruitment was done, and bleeding was a major issue. Then there were technical advantages, there were a lot of changes in the theory, hardware improvement, and improvement in the understanding and concept. So after the Caesar trial in 2009, ECMO 2 era, where there was an awake patient on spontaneous breathing with extubation, not on ventilator, the focus shifted from cardiac OT to an ICU nursing care. And ECMO team used to support the patient in an ICU, not in an OR. And lung recruitment and other bleeding issues decreased. Then is the third era, from 2018 onward, after the EOLA trial, where we are focusing on awake and an ambulatory patient. Ambulatory is very important. That really improves the recovery of the patient. Extubated patient, off ventilator. And even people are now focusing to give ECMO on a conventional care week or home treatment. So ECMO has become ambulatory, and for patient of ILD and other CO2 removal problems, the ECMO can go with them at their home. So the patient may not need to remain in the hospital with spontaneous breathing and perhaps no anticoagulation. So these are the three eras of ECMO which has developed from 10-15 years period of time. Now if we divide the total spectrum from pediatrics to geriatrics and from lung to heart, there are 6 groups: neonatal cardiac, neonatal respiratory, pediatric cardiac, pediatric respiratory, adult cardiac and adult respiratory. So entire ECMO spectrum is divided into these 6 basic groups. Now, if you have to talk about history, there can be many points, but I will take you through the salient point only. This thing I have already told from 1952 to 1975, the chronology of things which has happened. Then the trials. Almost all trials, either randomized controlled trials or cohort studies or case reports or single center studies, only 2 centers have shown that they were negative results, probably because of wrong planning. Otherwise, all other trials have shown a positive outcome of benefit by ECMO on such serious patients. The NIH trial that was from 1975 to 1979 had picked up around 230 patients, and in which 9 centers were recruited and 3 had no experience of ECMO at all, and they used homemade circuits, they were uncontrolled anticoagulation, and only 10% of the patients survived. This trial was stopped prematurely, and therefore, because there was no success in it, and because of that, this is the impact. You can see for 10 years, 1976 to 1984, that major endocrine control trial had such a major impact on all centers that there was no ECMO in that period. Otherwise, all other theories were going on, but that retarded the growth of ECMO because of a wrong trial. But the bailout was why Robert Bartlett is called as father of ECMO. So in spite of all the negativity, he did the first case, successful case at ECMO. He said, follow the winner. If he said neonatal, he was an adult cardiac surgeon. And in what he was doing, neonatal respiratory cases. He said, pediatrics, neonatal has got very good fighting power. They have got very good recovery power. So to do those cases first, you will get success there. And therefore he started concentrating only on neonatal respiratory cases. And so he continued with his efforts, and later by 1980, when Nanover in US and Europe was doing ECMO, he was doing almost 80 cases a year, and later by 1986, 18 centers across US started doing it. So he was a single string of hope who continued ECMO in spite of all the negativity, and therefore he is called the father of ECMO. So then came the CESAR trial. This was first NIH was a negative trial. The CESAR trial was for adult respiratory patients. Remember, ECMO for 25 years, from 1975 till 2000, was only and only neonatology and pediatrics. There was no adult respiratory or cardiac encouragement or sort of results happening there. So for the first time in 2008, when the CESAR trial was done, they showed that 57 out of 90 patients on ECMO versus 41 out of 87 with a p-value of 0.03 had a success by ECMO, thereby proving that ECMO is a good alternative for adult respiratory cases also. And therefore, after this trial, you find a big boom in the cases of adult respiratory cases, as you will see in the ASO registry later. Then in 2018, the EOLA trial came, which was also meant for providing ECMO for very severe acute respiratory distress syndrome when they come in the last stage. But this pickup point was bad because you are picking a patient when they are already very terminal and very sick and putting them in one cohort and trying to justify against other conventional group of patients which is not very sick. So the result did not come comparable, or ECMO could not be found superior to conventional treatment after 60 days of treatment. So therefore, this trial in 2018 was a discouragement. But apart from that, let us say, I will show you the outcome of ECMO in conventional patient. There was survival of only 28%, whereas in ECMO patient, the survival is as good as 68%. They were showing the difference of p-value of 0.001. So other cases done, if they are put on ECMO as compared to conventional treatment, the significance is great. This is another trial, 185 patients. The 60 out of 93, 66 survived. Conventional patient, only 30 survived out of 93. In Boston Children ECMO randomized study, 19 patient, 97% survival in ECMO group, 60% survival in conventional group. In University of Michigan prospective and randomized trial, almost all the patients survived, only one died. So the Research Society at US finally labeled them after 50 years of ECMO experience that ECMO is a viable option and it should be given to really sick patients. As you can see the statistics, the figures in 2004, after that ELSO was made, they made a registry and the registry is very strong and it has been following all the cases. Around 28,000 cases were done as by 2004. So by 2008, it became to 37,000 cases. Then by 2018, it came to 98,000 cases. Then by 2028, it came to 1,71,000 cases. And by 2025, it is around 2.5 lakhs of cases of ECMO done across the globe. Many of them not reported, but whatever reported, this is the numbers. And these numbers have grown very sharply. And you see after 2010, there's a very sharp rise in the number of centers and the number of cases of patients being done of adult respiratory and also adult cardiac now. Adult cardiac, there has been no randomized controlled trial till now, but slowly if some trial proves that if early application of ECMO for a failing heart would be beneficial, then that number will also boom. But of course, I would like to say the cardiologist that ECMO, if applied in time and to the right patient, will do wonders than many other machines. If time permits, I will tell you why. Then ECMO applied to cardiopulmonary resuscitation. If the conventional mode of CPR would have a survival between 2% to 20%, and eCPR, ECMO CPR would have a survival rate of 40%, just double. So you can't ignore this fact. And for a respiratory ECMO, you may have to wait for an epidemic, H1N1 epidemic, a COVID epidemic. But CPR comes to your hospital almost every week or maybe more. And there, if you practice eCPR, you will have a year-long supply of patients who may survive by application of ECMO. And all corporates are developing eCPR as a very robust program in their hospitals. So these are all the statistics of eCPR. ECMO survival is higher with isolated cardiac lesions. Acceptable neurological outcomes are seen with ECMO survivors. And that is all. So that is about, I will cut short because time is limited. These are already spoken. So we are at ECMO second era. The second era means we are looking at low resistant lungs, the oxygenators and safe pumps which are less thrombogenic. We are looking for safety, we are looking for circuits which are having a better convenience and a safe and easy vascular access and a better understanding of physiology. That is where India stands as of today. Improvement. Now, this was all about the principles of ECMO, but there has been a lot of changes in the basic circuit till now, like no permanent bridge, no better bladder, reduced surface contact of the blood, reduced priming volumes, increased speed, eCPR applicable, reduced number of circuit changes due to clot, increased period of low heparin units required, increased flow possibilities of flow in the breathing cannula, increased ease of movement of catheter CT scan and theaters. The circuit volume, which was say 1750 in older circuits, has come down to 1000 ml of extra corporeal volume, thereby decreasing the hemodilution of the patient. Then the hardware has become like anything. I would say that when my learning period of ECMO was between 2005 to 2010, where there was no ECMO training in India, and I used to go to various centers across Europe and America when they used to have the training program. And in each conference, if I pick up a machine and I buy that, the next conference I used to get depressed because more new machines used to come, more facility used to be there. So hardware has increased like anything. All the names you see, I will just go fast, only the figures to tell you that the hardware is always and very rapidly getting better and better, and is making the ECMO convenient and easier and easier. So for an ECMO circuit, you can see this is the component required for ECMO. I will just take you fast through all the component machinery. These are the additions of small components in the ECMO circuit to make it more accurate and make it more powerful. Then from these are the types of oxygenators, these are types of the bubble detector, these are types of the cannulas, and this is the type of the consoles, and this is the double human catheter. Then there are various monitoring like hemocritic and other things, monitoring parameter, the axial or the peripheral pumps are there. Then the type of the tubings, then the type of the monitoring devices, then the type of the oxygenators, then the microcirculatory circuits, then type of the consoles. They are all increasing and they have the advantages and disadvantages. So these are the technical improvements that have improved our performance. Previously the priming time used to be 20 minutes. Now the priming time is coming to less than 4 minutes. So this is a change in the configuration of the circuit, and the ease of the design which makes it possible. The triple element cannulation, the prototype, the DLC cannula, the Avalon cannula, the CO2 removal devices like AVC2R, Novolung, IL, APL, these are all the types of devices, the IL, these are all CO2 removal devices. Then the improvement in the design of the cannula, so flexible and still maintaining the human various length of the cannula. Then this is only extracorporeal CO2 removal devices which can either out of the corpus or inside the corpus. This can be changed periodically for removal of carbon dioxide. Then various type of in vivo catheters which I will tell you the novel development of ECMO technologies. Then mobile ECMO and ECMO transport from simple helicopters to aircraft carriers, the complete ambulance going. They have modified the treatment of ECMO. Then coming to a microscopic level, a molecular biology, the future is there because mechanically we have limitations. We cannot go beyond the size of the human vessels or the anatomy. So at molecular level, improved blood material interface, ideal circuit, improved anticoagulation and portability. So non-thrombogenic endothelium, anticoagulations other than heparin, biliverdin, agratarban, then coating services on the tubings by various chemicals to make it less thrombogenic. Effect of nitric oxide on platelets, then nitric oxide releasing or generating material from the plasma itself, endothelization on raw surfaces, then ambulatory paracorporeal artificial lung, then tracheobronchial transplantation if there are tracheal sloughing or damage with stem cells to make a trachea, because there is no trachea, the patient will be always on ECMO. So other devices to complete the deficiency in the body. So that is what is at the molecular level where the world is working on. Future of an ECMO. If I use only 2 words as a ventilator, how many ventilators there are in India? I would say there are 3 lakh ICU beds in India. I would say there will be at least 30,000 ventilators in India. So what I want to say is that if ECMO is used as a ventilator, then see the scope of ECMO. Why do we use a ventilator? I will explain in the next slide. If ECMO is used as a ventricular assist device, slowly the power of ECMO and the deficiency of ECMO is going down the drain and the applications are increasing. But if ECMO becomes as user-friendly as an IVP, then you assume the scope of ECMO for respiratory and cardiac cases. You will not have to think that you will have to find a patient for ECMO. Then for CO2 removal, for artificial lung, for ECMO transport, for organ transplant, for poisoning, for sepsis, for hypothermia treatment and for surgical elective ECMO. ECMO has got a great role. Why I said ECMO is a ventilator? She was a staff nurse at Leicester in England. She was herself an ECMO nurse. She had an ARDS. She said, no ventilator. I want to go in ECMO. See the comfort. Only 2 tubes going down the neck. She's talking, she's eating, she's comfortable. Therefore, ECMO as an alternative to ventilator is going to come in future. Then tracheal injuries and thoracic injuries and multiple puncture ribs and thoracic cage, ECMO is the only solution. Then the literature. There are more than 50,000 bibliography, of which more than 20,000 are only on blood and blood products. That is the volume of work people are doing in ECMO. And this was the first red book in 1976. And these are the publications, the standard textbook of ECMO from ELSO. These are the textbooks. Then ECMO has grown all across the globe. There are 5 centers. We are in SWEC ELSO, the South West Asia and African chapter of ELSO. And these are the distribution of various places everywhere. Okay. Now, that was about the spectrum. Now coming to indications, very important. I will not take much time. Other people have covered VA, VV, ECMO. I am not going to talk on them. But I will just talk on one important thing. Yes, ECMO is everywhere. Previously, ECMO was the stepchild in the corridors of the OR of a cardiothoracic surgeon. Now ECMO is in every ICU, in respiratory ICU, in cardiac ICU, in medical ICU, in surgical ICU, in emergency room, in neuro ICU, in neonatal pediatric and transplant ICU. So ECMO is everywhere now, in critical care. I will not, okay, I will leave this part also. But the result, the survival rate of a respiratory ECMO ranges from 72% in neonates to around 50 to 60% in adult cases. This also part I will take it. You know our indications of VA ECMO. I always want to carry this slide. Whenever we talk about VA ECMO, I would just always make a point that we don't think of ECMO unless we are very late. Unless the inotrope score crosses 100, then we start talking of ECMO. Whereas the ECMO should start when the inotrope score is 20. At 40, it has to be actually applied. If we say in India because of economy and because of self-funding, there is a problem. So you start discussing with the relatives that ECMO inotropic score of 20, and at 40 at least you should apply. I find inotropic score for more than 160, 200, then also people don't offer ECMO. Then they say the results do not come. How can the result come? Because the patient has already gone into peripheral circulatory shock and a multi-organ failure and a renal shutdown. Then when will the result come? So ECMO has to be applied in time. ECMO in medical ICU, in septic ICU, ECMO in poisoning. Your center is doing a great job in poisoning that you already witnessed. But septic shock also is a challenging field, and in other areas of medical ICU, ECMO is a great role. For hypothermic coagulopathy and for rapid hypothermia correction, there is nothing better than ECMO. This I already told you. ECMO and ECPR already covered. ECMO in transplant ICU, both for pre-transplantation, during transplant and after transplant, both for donor and recipient, graft rejection and for organ support and for organ preservation. And even if the patient dies, then organ donation. ECMO is the backbone. ECMO is the backbone. It will help make anything. That is extracorporeal internal support for organ retrieval, EISOR. So for cardiac donors, in fact in India में कोई cardiac donor है ही नहीं, but फिर भी cardiac donor है, if the patient is an CPR patient, you put the patient on ECMO. Unfortunately, the patient is brain dead. That patient is a very good candidate for a cardiac donor. So that is where the organ donation work will improve. Then I go in vivo preservation of lung. If lung transplant is a very difficult subset, put the lung on an in vivo at normal temperature, normothermic, on an ECMO circuit, the lung will be better preserved. the time of initiation. Again, for respiratory ECMO, there are two criteria: when to start considering and when to apply. Similarly, cardiac ECMO, when to start considering and when to apply. Because in India, we take time for giving a consent and finances. Then the very important topic, this I was talking about the present. Then translation research. Translation research has got three topics: implantable wearable artificial lung, artificial placenta, and organ bank. Try to understand, there's a patient, organ donor. Now, all the centers cannot reach at the same time. Or you take the organs, put them on a ECMO hanger, the ECMO maintains the circulation, the organ is preserved, then time delay is not a problem. So an organ bank can be constructed to maintain the tissue integrity, and the time for the 3 hours time can be extended. Ambulatory artificial lung, I've already told you, showed the diagram. Then artificial placenta, I will cover later on. Very interesting topic. Then organ banks, still yet to come in India. Then again, in this 50 years, not only ECMO the thing. There are many things behind ECMO. If I say ECMO has a science, it has a library, it has a registry, it has an education, it has got guidelines, it has to be trained, it has to be propagated. So if Fontainebleau is looking after the ISO organization and predictions and steering committees and opportunities and education and registry and websites and red book and etc. So education also is a part of the development of ECMO in these 50 years. So I will not go into this again. Then there are pioneers who have focused into the clinical research. If neonatal respiratory ECMO was pioneered by Bartlett, it grew for 25 years from 1975 till 2000. Adult respiratory in 2008 was pioneered by Jaitsky. Then adult respiratory took a boom from 2008 to 2018. And now also, adult cardiac is growing on, but Alan Coombs is working on so many aspects of myocardial infarction, myocarditis, arrhythmias, etc. What is the advantage of applying ECMO? All this literature is helping everybody to apply ECMO in cardiac cases. Poisoning, our Dr. Vivek Gupta is the pioneer of treating sulfose poisoning in the country, maybe in the world also. More than 180 cases done. ECPR, septic shock, organ transplant, all those things. And as soon as these things happen, there is a boom in centers and the number of cases of ECMO and the number of patients benefited. You can see this thing. Now again, coming to, and it will look like imagination, but please look at it. Novel approaches for acute respiratory care. We said the oxygenator membrane, the hollow fiber, the pseudomembrane is the integral part of oxygenation of the blood. Now, Dr. Conrad, S. Conrad, he is working on making a filter in the IVC itself, where all these fibers are like a mesh in the IVC from IVC to SVC, and they are generating oxygen and releasing oxygen inside. So it is an in vivo ECMO. He is working on a project called IVOS, where instead of outside, the ECMO is taking place inside the body. So these are the membranes he is making up, along the intravenous cable membrane oxygenation and carbon dioxide removal in severe aortic respiratory failure. He is working on it for the last 15 years. He has not got success till now, but he is still working on it. Along with, then he applied a balloon inside it. The balloon will do pulsations and will move the oxygen in and out. So that, along with Dr. Hetler, he made a Hetler catheter on which spirally the pseudomembrane fibers will be tied, and the balloon will inflate and deflate, and that will push the oxygen up and down, and that will deliver oxygen directly into the IVC. So there will be no circuit outside. Everything will be in vivo. So this is the patent they have taken. This was the physical concept. Now the chemical concept of delivering intravenous oxygen by generating oxygen through nanoparticles and spherocytes or aspirocytes. So they tend to generate oxygen from within the fibers through microbubble physics. I am nanoscale tech manufacturing. I also do not know. They have not declared anything, but they are doing something. They spoke in one of the conferences. and nanoscale 3D printing to make respirocytes. So respirocytes will be fitted into the membrane of the hollow fibers, and from there they will be generating oxygen, and it will be directly getting released into the blood. So these are the respirocytes they are making. It will get fitted into the pseudo membrane of the filter, and it will get endothelized. So it will be a permanent technique. So this is the respirocyte design that will go into the hollow fibers, and they will get endothelized, and from that endothelized cells, nitric oxide will be released and oxygen will be released in the intravenous cable oxygen release. So, and they are developing micro manufactured capillaries in order to have a network, a syncytium, so that it covers a wider area. So, and are making a functional endothelized microvascular network with a cross-section, increase of cross-sectional area and tissue on a tissue culture plate. So innovation and oxygenation is expanding. Novel approach is likely to alter our practice in future. Nanotechnology has got an immense power, and hybrid technology and biological sciences will shape the future, and the future will be exciting. That was about then artificial placenta, very important. We have a golden past, even in, you know about the Kauravas, they came out from an artificial womb or artificial placenta. They were not born directly. Hundreds of them came out. We have a history like that. So why do we need an artificial placenta? Because the viability life starts after 26 weeks, more than 600 grams of a baby. If the baby is born at 20 weeks, 22 weeks, 24 weeks, very difficult to save them in ICU. So that time period from 22 weeks to 26 weeks or 24 weeks, between 400 gram baby or 600 gram baby, that is the period. That population is 9 lakhs to 12 lakhs population in the world who die, who because of prematurity or because of early abortion, they die. They cannot be survived. Their artificial placenta and artificial womb will work. How? So it works on a, I'll show you. 5 centers are working on it, but artificial placenta, you can see this figure. In this figure, this was designed by Robert Bartlett himself. What is artificial placenta? As the baby is born, it is in animal experiments, but Japan is already on the process of doing it in humans. So, like a normal cannulation from the umbilical artery to the intraventricular vein, VV is done in lambs, the fetal lambs, and in them they don't require the placental fluid or anything. They are just like an external VV ECMO. So that is artificial placenta. If that cannulation is difficult, there is an artificial womb. Artificial womb is putting the baby in a plastic bag filled with an amniotic fluid-like environment, and you do oxygenation and carbon dioxide removal from that fluid from the bag. That will also take care of the renal replacement and as well as the nutrition of the baby. So that is an artificial womb. So both this artificial womb and artificial placenta are part of ECMO technologies which are already successful in animals, in fetal lambs, but they have their planning. It has yet to come out of ethics for permission. The ethics is already given for only 4 weeks, not for the entire genesis or from the complete development of baby. But centers, this is the diagram what Robert Bartlett showed about the artificial placenta. And this is a diagram of artificial womb. And these are the babies who can be saved. This is in lamb which they are showing. You can see this lamb was, and this lamb, in 4 weeks time the wool has grown over the lamb because of the remaining artificial womb. This is the circuit diagram. This is this, and you can see the difference. And this is what Japan claims to be. It is creating the first artificial womb theory, and they want to make the thing in a balloon and to be suspended, and they can grow the fetus there. So there are theories like this.
Thank you.
कॉम्प्रिहेंसिव टॉक ऑन एक्नो। तो सर की मैं कुछ बातों को वापस चाहूँगा कि अपन उद्धृत करने। सबसे पहले सर ने बोला कि अगर चिकित्सा विज्ञान मिलिट्री है तो एक्नो वाले उसके कमांडो है। सो कमांडो मीन्स वी हैव टू बी फिजिकली फिट, वी हैव टू बी मेंटली फिट एंड वी हैव टू बी स्पिरिचुअली फिट, बिकॉज इफ यू आर पुटिंग पेशेंट्स ऑन एक्नो दे विल टेस्ट यू ऑल दीज थिंग्स। दूसरी चीज़ के सर के इतिहास में बहुत लंबा था वैसे, लेकिन फिर भी इतिहास के अंदर ना बहुत असफलताएं मिली है। जयपुर का जो फर्स्ट रैंडमाइज्ड ट्रायल था उसमें जयपुर साहब ने तो यही बोला था कि ARDS ECMO is not useful for ARDS. He totally came out with this conclusion that ARDS में ECMO का कोई रोल नहीं है। हाँ तो ये ECMO, लेकिन वो तो thankful to the Italian guys get him on the so they kept on doing one ECMO. 15-15, 20-20 साल के गैप हैं जब ECMO के अंदर नए माइलस्टोन्स आए। सो ये ECMO की कहानी ये भी है कि असफलताओं से हमें कभी नहीं डरना चाहिए। तीसरा सर ने बोला कि अभी भी दिस इज स्टिल इवॉल्विंग, इसलिए कोई भी चीज़ होती है तो बेहतरी के लिए बेहतर, एनीथिंग कैन बी ऑलवेज बेटर देन व्हाट इट इज राइट नाउ। सर एक बात बताइए सर, भारत में ECMO का क्या तो इतिहास रहा, क्या स्थिति है और आप क्या इसका भविष्य। एक और सर का कॉन्सेप्ट बहुत अच्छा लगा, मैं आपको उसको वापस उद्धृत करना चाहता हूँ, दैट इट कैन रिप्लेस वेंटिलेटर्स। ऑफ कोर्स इफ ECMO बिकम्स अ सेफर मोडेलिटी, of course it can, we can think of replacing it with ventilators, and that another substitute for the lung transplant, we can put some devices inside our body that can oxygenate and can remove the carbon dioxide. It will be a wonderful thing for many of our NCOP patients and IV patients who are waiting for lung transplant for indefinite time. It's a very horrible journey for those patients. Sir, Bharat ke baare
I will tell you 2-3 points.